around 10 to 15 minutes, I will conclude about tips and the tricks of Ayman Morsi clinical activity. And this important for all cardiologists supposed to be know. It is not the issue to testing your knowledge, just only piece of information, especially lipidologist and the cardiologist. Burden of cardiovascular, and we specify about our era here. LDL play crucial and central role in cardiovascular disease, risk prediction and classification, what's guideline safe, and we also concentrated about Saudi guideline. And we will see here tips and the tricks, questions, just answer yes or no. 54% of Saudi population between age of 30 to 70 are hypercholesterolemic, yes or no? Only thing, perfectly. Elevated lipid, it is the greatest impact of MI versus other common risk modulations, right? Perfectly. No any harm, this important thing for cardiologists, no any harm for nourished body cell if you decrease LDL level less than 25 milligram. Yes, so what's the benefit of my lecture then? According to recent European Society of Cardiology, you can decrease LDL to less than 40 milligram, not less than 55 milligram. Nicely. Okay, the target of LDL according to Saudi dyslipidemic guideline 2022 is not go to less than 55 milligram like European Society of Cardiology. What Saudi guidelines say, not 55, go to less than 40, right? Lastly here, statin intolerance, this important message. Statin intolerance tends to affect women more than men. And this is the answer. Bembotic acid is one of the very good therapeutic option. Don't jump to BCK9 inhibitors against the wish of company. There's a way to go. Lastly, bembotic acid is working in the same pathway as a statin therapy, but it is work downstream in receptor mechanism. No, fine. Azatamide must be follow the high intensity therapy regimen before you start the BCK9 agent. You must be follow or you not must be follow? Perfect. Your water tap is broken, which lead to collection of the water to your private bedroom. You must be repair the water tap, not remove the collecting water. This is how to mechanism of action in both BCK9 inhibitors. Somebody acting in the tap and the other BCK9 inhibitor acting here. Lastly, for our patient, you like to give them medicine injection twice yearly or twice weekly. Treatment, very important message here. Treatment with 6 months dosing schedule of inclisiran over 18 months in patient with recent MI or remote MI or no prior MI is associated with comparable efficacy and safety profile, and all these three groups experience an early LDL reduction more than 50% from the baseline, i.e. after the first dose only. No. Fine. This is the issue we're supposed to go. The issue of here, of dyslipidemia, not the pill, in order to everybody looking for me. No, we need asking for the visceral fat, right? So 37% of total deaths in KSA due to cardiovascular disease, and I think everybody knows about this issue, as if you can see here. Quickly, real life ACS regimen or registry in Gulf area, all of them saying very nicely to say, see how's the number? 34,000 ACS patient over 15 years, young age, high risk factor, LV dysfunction, and severe diffuse CED. That's why always in our area, you can see very nicely the patient in our era, it is decade younger than the rest of the people. Very common slides, very common. Right, here 1 on 3, after MI or stroke, the risk of another event is 4 years, within 4 years, 1 on 3. So LDL play as a crucial and central of cardiovascular disease, so we need to tackle the dyslipidemia from here. Even before So any diastolic dysfunction in this parameter due to CED is supposed to be tackled from the early. Don't waiting till the MI coming. Here, the MI is the one of the elevated left risk factor greater impacts in MI risk in compared to the other, as if you can see here. Lastly, see how the timing after ACS are very, very important. 10% of the patient after MI die within the first week, and 7% of the patient die in the first 150 days. 10% of the patient, at least, there is another event in a year. 12% of the patients, additionally, 12% of the patients die in the first year. So we want to tackle this area or this timing. First year post-ACS is the most vulnerable timing. Here, you can see MI in homozygous in 12.5 years, right? And here, we have family here in this era coming by MI in 13, which is treated in our center. We have family, 3 boys in same family, take medication, and the MI have in 15 years, BCI in 18 years. Now all of them is post-cabbage in one family. But the era of the usual without any risk factor is aging of 50s. Right. Definitely, all of the study mention the LDL more low is more better. That's why every 1 millimole, as if you can see here, decrease the cardiovascular around 20 to 23. But there is very big gap. See the difference between low intensity statin therapy and high intensity statin therapy. You can see the difference is little bit, not significantly, but still very huge residual risk, and we want to cover this risk. This from what? This from 1985. Both guys take Nobel Prize about what? You can go down to LDL less than 25. Not less than 40 even, 25. Fine? This is 1986. What is the risk prediction and the classifications? Here you can see this is my concern. We take right patient, right time, right therapy, and the right intensity. This is what we can say cardiovascular risk category. Very high risk means score of 10 years risk more than 10%, and most of our patients acting in this very high risk. Very high risk, we asking about what? Recurrent events. Document CED or atherosclerotic vascular disease per se, it is very extremely high risk, like patient of MI, and the patient even in type 1 diabetes with duration more than 20, CT coronary angiogram, even radiologically, see 20 to 30% CED, it is extremely high risk. We want to say everybody knows these slides, but always you concentrated here. An extremely high risk patient, it is not less than 55, it is around 40, meaning less than 1 millimole. And most of our patients here, not less than 55, less than 40. This is the guideline. The guideline between 2016, European 2019, they mention 1 or 2 important things. Instead of less than 70, it has become less than 55, and they remove or and they put it and. This is a guideline nowadays. Saudi guideline mentioned no, we need more tight. Here, the guideline and safety. See how Saudi guideline mentions? We go all our Saudi patients less than 40s. Not less 55, less than 40s. Fine. So 2019, they mentioned second preventions is go less than 55. Primary prevention for individual for familial hypercholesterolemia by class 2A, again less than 55. And this my concern alwaysly. Patient of the recurrent events alwaysly gets less than 40s. So they mention safety of low LDL. It is no any harm if you go even less than 1 millimole per liter, mean less than 40. So we speak also about less than 40s. Right? For secondary prevention of patients of very high risk, not achieving goals, so statin therapy, you can escape azithromycin therapy. In order to azithromycin only decrease to 10 to 15% of LDL. So you can go quickly from high intensity statin therapy, escape the azithromycin and go by BCK9 inhibitors. Here, in all ACS patients without any contraindication, definitely high-intensity statin therapy regardless of LDL. Again, the guideline, most of the guideline mentioned very nicely, go by moderate statin therapy, high-intensity statin therapy, and then azitamide. If you are not reaching the goal, go for PCSK9 inhibitors. This is my concern in order to, they mention very nicely, don't follow the rule if the patient is go from high intensity to go quickly for BCK inhibitor and escape azitamide. In order to, azitamide is always the bad guy and small and weak. It is decreased LDL level around 10 to 15%. This is a guideline statement, not our statement, by the way. Here, there's very nice slides, and everybody knows. High-intensity statin therapy alone decrease LDL around 50%. If you go by azitamide, it's 65. So the difference between both of them, only 15. Only 15. Lastly, if you go BCK9 inhibitor, 60. If you join all of them, it's around 85. The more important thing here, supposed to be your patient have the target of LDL less than 40s. Supposed to be stop statin therapy, the answer is no. In order, it is very common, I've seen in our practice now. So high-intensity statin therapy, in order to statin therapy have pleiotropic effect, BCK9 inhibitor is no. So the most important common question in our practice, I see always, patient becomes the target. I stop statin and continue BCK9 inhibitors. The answer is no. Right. Okay, fine. So what is the obstacle here? This our national, Dr. Arafa, 76% of patients of LDL, these patients receive lowering therapy but never ever go to the target. Even here, 80.5 in Germany and the 79.7, around 80% in America. All of these people, approximately 80% of atherosclerotic coronary artery disease not reaches the target. And these publications, the target at the time is less than 70, not less than 55 even. You can see very nicely here, all this country here, even America, around 90% not reaches the target, right? Again, very quickly here. The most important common cause of stop of the statin therapy mostly to the side effects and no longer needed according to them. So mostly we need something to be corrected. BCK9 is a solution. This is the agent of LDL lowering by BCK9 inhibitors, and I think soon or later you will see BO medication of BCK9 inhibitor within 8 months. You can see medication like statin therapy, not injectable, right? And then Evolocam, and then Elclasiran. Elclasiran therapy, as if you see here, is 50 to 52% reduction of LDL. But the mechanism of action is very nicely in order to, stop the production from here. Is not lead to the patient go to here and then stop from peripheral. So the Elclasiran, in compared to other BCK inhibitor is stop the production from the start. Lastly, so this is the one which is, can I say very nicely, always we want to stop, don't treat this issue. We want to treat the root from here. Right. So the BCK9 inhibitors, either Evolocam, or small interfering siRNA, which is most of the time is injection twice yearly in compared to the others. So Elclasiran siRNA for BCK9 inhibitor, which is so very perfect LDL reduction with good tolerability in severe form of hypercholesterolemia, as well as high cardiovascular disease profile with injection every 3 to 6 months. This pool analysis we can see, which is a program which is mentioned nicely in March 2021. They mentioned very nicely program which is called Orient Trials, which is 9, 10, 11. The 9, it is expected in patient only in familial heart or heterozygous type, but the Orient 10 is secondary prevention in patient with atherosclerotic coronary artery disease. In Orient 9, 11, it is primary and secondary prevention. You can see this program is 3,660. You can say all these type of patients, either primary or secondary prevention, all of them is included, and the net result, you can see here, this is a way to go. First visit here, patient injection, 1 injection here in day 1, visit 1, and then after 90 days only second, and then twice yearly. This is important, by the way. Okay. So our chairman say you want to go quickly to answer the questions, right? Fine, fine. Shall you go for answer my concern? I can see from here. And supposed to be no. Bismillah. This one, 54% of Saudi citizens, all of them have hypercholesteremia. The answer is yes. Second one, elevated lipid, greatest impact in MI in compared to the others. The answer is yes. No harm to go down up to 25 milligram per deciliter, definitely. Target LDL, according to 2020, is less than 1 and 1.4. Or no, yes, the answer is go down more than less than 40. According to recent European Society of Cardiology, you can decrease LDL less than 40 milligram, not less than 55. Lastly, statin intolerance is one of the important to be treated before BCK9 by bempedoic acid. The mechanism of action, it is not the same mechanism of action in the same receptor. Lastly here, azetamide not follow the rule except if your patient have only gentle decreased 10 to 15% reduction of LDL. Otherwise, high intensity statin therapy and go quickly to BCK9 inhibitors. Your water is important in order to it's acting the mechanism of action. So we need to stop from here, from the production, not from here. Lastly, not least, for our patient, you like to give definitely for the issue of compliance, we give twice yearly instead of twice weekly. This is the important message for all the Orion program. So all of these patients, either recent MI or remote MI or no MI even, you can say one injection of inclisiran therapy, you can decrease 50% from baseline from the first dose. Lastly, the take-home message, cardiovascular is still big burden all over the world, in Saudi Arabia mainly. LDL, one of the important player with crucial role in cardiovascular regression, a strong progression relationship achieved by LDL and the cardiovascular event, no excessive safety event with very low achieved LDL, even less than 20. As a cardiologist, we need to predict the risk of cardiovascular disease and treat it LDL according to the guideline. We want to close the gap between the practice and the guideline. And thank you very much.
Thank you very much, Dr. Ayman. I think it was a very nice presentation. Do you have a quick 1 or 2 questions before we move to our symposium? Yes? No? Okay. يديكم العافية. شكرا دكتور أيمن. Yeah, go ahead.
You mentioned quickly about the use of inclisiran versus BCK9 inhibitors. From clinical side of view, practical side of view, I find it a bit more towards BCK9. It's good to have this medication given only twice, but the thing against this is that it's a double-edged sword. You as a clinician and the patient that comes off as well, you will tend to forget what's the time due for the next dose. However, if your life has been going smooth regularly every 2 weeks, that will make you on track. But you know, if you have received, oh, I have scratched my head, when was the last dose? When will be the next dose? I will forget as a patient, leave aside the physician who is busy with many things to remember the next dose for the patient.
Excellent. This point is very valid, honestly. And always I ask this question only. So my concern always for compliance issue, definitely twice yearly. You are rightfully. But my concern is who's supposed to give in the inclisiran till now? It is not you by your own, from hospital. It is a hospital. So the hospital and the program of dyslipidemia in your hospital is the one responsible to remind your patient. But as a compliance, definitely twice yearly is better than twice weekly. Right or no? Thank you.
No. How can I utilize? السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا ونبينا محمد وعلى آله وصحبه وسلم. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. At the beginning, I would like to welcome all of you for attending the second International Echo Conference for Almoosa Hospital. And we are very happy to see you again this year. Inshallah, today we already started in the morning by the two workshops, one for the technician and the other one for the physician, transesophageal echo with hands-on and simulator, and the other one for the technician for acquisition of the images 3D and strain. And the other part of the workshop is still running now upstairs. Now we'll start our very fruitful part of the conference, and always there will be competition. Today, the competition for the interesting echo cases. The competitor today is 14 person. Already there is, it was before 21, but the problem for some people apologized at the last minute, so it became only 14 presenter. The format presentation for the formation for this presentation, just everybody will concentrate on the 7 minutes for the case presentation, including the videos and the images, and 3 minutes for literature review and the take-home message, and 3 minutes for discussion. This year, we increased the minutes for discussion because already many cases are very good and very nice. That's why you want everybody to stick to the time while his presentation and not take more time, because it will all affect his mark also, which will be given for him. Our referees, it must be 5 referees, Dr. Hassan Shams Basha, Dr. Abdul Halim Kinsara, and Dr. Ashraf Anwar. But the remaining 2, Dr. Gurmala Zahrani and Dr. Fatma Qaddura, is still on the way. That's why you will not be with us now. Okay? We will concentrate for the referee. Dr. Abdul Halim Kinsara will talk now about this. Already will concentrate on these items. Dr. Abdul Halim will talk about the details about this to be stuck for these items, all of this. And at the end, the best 3 cases winner will be honored with precious prizes tomorrow, inshallah, in our opening ceremony. So we want all of you to be committed to the time, and also to the, already to the, as we said about the discussion, to get high marks to be one of the winners. Dr. Abdul Halim, you can.
شكرا جزيلا. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيد المرسلين. I'd like really to thank Almoosa College, Almoosa Hospital for really hosting. This is a very important event. والشكر جزاه الله خير الدكتور علاء على حرصه على اهتمامه على collecting all these experts. I think it's really for the people who are in symposiums, you know how it's a big headache. فشكرا جزيلا دكتور علاء، الله يبارك لك في علمك وعملك وينفع بيك. طبعا as you know, this is for the second time we are doing it. The cases will be presented by each speaker, and there will be 3 people will evaluate each case. The most important thing, please to stick to the time. We're really going to switch off the screen. The assessment will be depending on 5 important points. Will be scored from 1 to 5. Now, the quality of the slide layout, which really does the case showing from the video, is really expressing what you need to inform the audience or not. The quality of your presentation, of the video, of the images, of the M-mode will be again important. So if you like show us from different method, including 2D, 3D, of course that will be a plus. A message from the M-mode will be again a plus for you. The quality of the images will be, I think majority of you will not have an issue because, to be honest, looking to the names, or if you are a star in the echo field. So I don't think the quality of image will be an issue. Now, the most important thing is the relevance of the attached discussion, because sometimes you'd like to give a lot of information, but you have only 3 minutes. You could get more minutes if you decrease your time in presenting the case. But most importantly is have really to be relevant to the case. Now, if you speak about aortic vegetation, there's no point to hear about mitral, tricuspid, and so on. So I think this is again very important. We are doing that because of the time. And of course, if your message take home was clear, something that is we missed, something that is we don't address properly, I think that should really score higher than a traditional message from straightforward case of infective endocarditis. I hope that clear. And I told you, I think we are putting this score because of you are really star experienced people. So it will be very difficult to choose. So I thought we will make it a little bit of fun and have a different way of giving the score. All the best. نالكم التوفيق. We'll start now. تفضل دكتور حسان عندك أول واحد.
Okay.
عندك أنت؟ Okay. Yeah. تفضل.
بسم الله الرحمن الرحيم. The first presenter will be Dr. Hatem Khairallah. He's a consultant cardiology and echocardiography in Prince Sultan Cardiac Center, and he will also have certified board in cardiac CT, certified board also in nuclear cardiology, and have a lot of national and international publications. Dr. Hatem.
This one? So don't count down yet, huh? Okay. You are not counting yet, okay. Okay. Okay, so my presentation is titled Mad Mitral Valve, and during the course of my presentation, you are going to know why. I have no conflict of interest pertinent to this presentation. This is a patient who is 35-year-old, no past history of note, except he is a smoker. He presented with ventricular fibrillation arrest. He had no shortness of breath, no dyspnea, good exercise tolerance, physically fit, functional capacity was okay. Just sudden cardiac arrest. ROSC was fortunately achieved after CPR for 20 minutes and 3 shocks. As an immediate response, we did ECG, echo, and coronary angiogram the same day. This is his ECG immediately after, which wasn't showing anything significant. And this is his coronary angiogram. Again, nothing significant in the way of obstructive coronary artery disease, apart from slow filling maybe. We did the echo, and as you see here, there is a mitral valve, myxomatous mitral valve with prolapse, and there is mitral annular disjunction, as you see there, and there is severe mitral regurgitation. The initial evaluation of the ejection fraction was 45/50 by Simpson. But 2 days later, we repeated the echo, and the ejection fraction by Simpson is 60%. We have also elicited that there is a high spike in the lateral S prime, high spike reaching 17 centimeters per second, which is a Pickel-Hope sign. We have done the strain, and as you see on the left side, there is heterogeneity of the strain, and the strain rate is showing kind of mechanical dispersion. So the time to contraction was kind of heterogeneous, okay? So we collected all these data from the echo, and we did TEU as part of the workup, and as you see, there is excessive tissue redundancy and prolapse, which is significant. We evaluated the MR by volumetric assessment, and it was proven severe beyond any reasonable doubt. So the hospital course patient was extubated, but unfortunately re-intubated and persisted on that for 2 weeks. He developed fever, post-arrest psychosis and amnesia, which lingers on for quite some time, for which we did EEG, CT brain, and brain MRI, all of which were unremarkable. We also did cardiac MRI, and here it is. There is subtle fibrosis at the basal septum. They have also remeasured the mitral annular disjunction, and it is 1.2 centimeter. So for this patient in particular, we thought that this is sudden cardiac arrest is not due to the severe MR, and it's not due to the LV dysfunction, which was lacking in this patient. It is due to the arrhythmogenic variant of mitral valve prolapse, which we have elicited the sign of that kind of malignant phenotype of mitral valve. So we discussed the patient, and we elected to go for surgery because surgery is probably going to treat the MR, though he's not symptomatic in that respect, but it's going to treat the arrhythmogenic potential of the MR. But unfortunately, the psychosis, the amnesia, and the fever stood in our way, so we prefer to discharge the patient and bring him back for surgery. But we cannot discharge him without an ICD, so we put an ICD, and he was brought back in 10 weeks for successful mitral valve replacement. So the prolapse can lead to mitral regurgitation, heart failure due to LV dysfunction, infective endocarditis due to the redundancy and the endothelial injury, stroke with or without atrial fibrillation, but most importantly, which I would like to stress in this case, ventricular arrhythmia leading to sudden cardiac death. So it's high time to look at the mitral valve from different dimensions and to broaden our insight into the mitral valve prolapse. So it's not about the mitral regurgitation, it's not about the LV dysfunction, it's about the arrhythmogenic potential of the valve. And this has ventricular factor, mitral valve related structural factors, and mitral valve related factors, and even extra valvular factors like autonomic nervous dysfunction and these things. So the malignant mitral valve prolapse, we know that prolapse span a wide range of variability from fibroelastic to the extreme myxomatous Barlow's variant. The malignant mitral valve prolapse relate to unique properties, mechanical abnormalities in the mitral valve apparatus and adjacent myocardium. The malignant phenotype can induce life-threatening ventricular arrhythmia even in the absence of significant MR and or LV dysfunction. And the reported incidence of mitral valve prolapse in sudden cardiac death varies from 1.2 to 8% in autopsy-based studies. And if we base that on age, if the younger, less than 40 females, 30% of the sudden cardiac death victim were found to have mitral valve prolapse. So it seems kind of a robust problem. And there are a legion of insights into what are the particular factors that leads to the arrhythmogenic potential. So they have studied, so many studies I have just plotted here in this crowded slide. But basically it's about the abnormality, structural abnormality of the mitral valve, the mitral annular disjunction, the Pickel-Hopf sign, the LV dysfunction, and the fibrosis. The most important are the traction and strain size. So now we know that there are two pathways in sudden cardiac death in mitral valve prolapse, MR related and non-MR related, like the patient I have just discussed. So the mechanical traction plays an important role in driving myocardial fibrosis, and this leads to ventricular ectopy and sudden cardiac death. So what are the traction signs that we have to elicit in all patients on mitral prolapse? They are mitral annular disjunction and Pickel-Hopf sign, and the strain signs are the mechanical dispersion, the post-systolic shortening, and the regional heterogeneity. And in our patient, we have elicited the mechanical dispersion and the regional heterogeneity. Like in this is MAD for a patient who also presented with syncope. It wasn't sudden cardiac death, but syncope, and you see the MR was just mild. So mitral annular disjunction is the separation, the anatomical separation between the posterior mitral annulus and the posterior myocardial wall. And how much depends on how severe the arrhythmogenic potential might be. The Pickel-Hopf sign is the sudden spike in the S prime due to the papillary muscle tugging. So it leads to swift peak, and that reach up to 16 centimeter and above that. And Pickel-Hopf sign is the German cap, that the one looks on the right. There is also the strain, characteristic strain features of mitral valve prolapse, the malignant phenotype, and these are the post-systolic contraction. Post-systolic contraction, the one on the right, and the heterogeneity of the mechanical dispersion as shown in the strain rate. You see it in strain rate. So again here, the post-systolic shortening and the mechanical dispersion, and sometimes the double peak strain pattern. So there is kind of heterogeneity in the myocardial contraction due to the friction and due to the inhomogeneous pull of the papillary muscle. So there is kind of mechanical dispersion and double peak of contraction in some segments. And this one has also been shown in studies to correlate with late gadolinium enhancement, the double peak pattern, and to associate with the incidence of sudden cardiac death. Here again is the strain in patient of mitral valve prolapse compared to the control on your right. Those who have strain, especially with late gadolinium enhancement indicating fibrosis, they show this kind of heterogeneity in the strain pattern. So now it is so important. Okay, it's so important that sudden cardiac death is no longer mitral regurg and LV dysfunction. We have to gather clinical data, ECG data, and imaging data, all of that, to have a full comprehensive picture about what mitral valve prolapse actually is and the arrhythmogenic potential. So we need echo, we need MRI, we need ECG, we need all of that. So in a nutshell, malignant phenotype of mitral prolapse can be identified by echo along with clinical ECG and advanced imaging. Mitral annular disjunction, Pickel-Hopf sign, and the characteristic strain pattern should be elicited in all patients. The treatment include medication, ICD, and cardiac surgery, and the benefit of mitral valve surgery is likely limited in malignant mitral valve prolapse when fibrosis has already been established. Benefit can be maximized by identifying patients at risk. Surgical indication for patient of malignant mitral valve without significant MR has not yet proven. So a new idea is first condemned as ridiculous, then dismissed as trivial, until finally it becomes what everybody knows. Thank you so much.
For questions? Yes, go ahead, please.
Thank you, Dr. Hatem, for this very good case. Having said that the ICD indication here in this patient is a secondary prevention, my question is that the time to risk stratify patient with mitral valve prolapse and patient with high risk? So yeah, in your opinion, what will be done for the mitral valve, whether repair or replacement? Would it decrease the risk of sudden cardiac death in a high-risk patient?
Okay, thank you so much for this question.
Is that the time to, the guidelines to be changed for primary prevention ICD in those type of patients who have high risk mitral valve disease, I mean? Thank you.
Thank you so much. The jury is still out about this. This is a very nice question because we have not reached the level of guidelines, but you know that mitral repair or replacement can eliminate the arrhythmogenic potential if and only if there is no established fibrosis. Okay? So that's important. That's why we have to go comprehensive with mitral valve prolapse, do the echo and do the MRI and see how things are.
Yes.
شكرا دكتور حاتم. بس about S prime and الماد, there is like number that suggests that this patient is more increasing risk than the others. And also there is, how can I differentiate between MAD and pseudo-MAD يعني from the views of ecos, because sometimes it's like conflicting or يعني similar to each other.
Yeah, thank you so much. This is again a very important question. Now, the MAD, the figures, any MAD is significant, but MAD more than 1 centimeter tends to bear higher risk. So 1 centimeter is kind of a magic figure, but things might change. Now, for MAD and pseudo-MAD, now MAD, it can be seen in all orientations. So you can see it in parasternal, in apical 2, 3, and 4. Okay, so you have to make sure that you are seeing probably in at least 3 orientation, and make sure that it is kind of morphological detachment of the posterior annulus from the posterior myocardial wall, or else you might get false impression of a MAD which is not there. Okay.
Okay. Thank you very much indeed. Jazakallah khair. Excellent. بسم الله الرحمن الرحيم والصلاة والسلام على سيد الخلق والمرسلين. Good afternoon, ladies and gentlemen. It's a great pleasure to be with you for the second year. And I would like to thank Dr. Ala for giving me the opportunity to be with the organizing committee, to be with you this afternoon. I'm going to present the second speaker, Dr. Ayman Morsi. He was just presented, and he is actually a consultant cardiologist at An-Noor Hospital and a professor in Al-Qura University. Dr. Ayman.
But it's very nice. Okay, nice. Yes, yes, thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh. This my concern about how the echo can solve the medical mystery, right? So, and I make it here puzzle. I make it here some puzzle. Why? We'll see now. The case scenario, 38 years old male patient, presented by congested cardiac failure, dyspnea, tachypnea, or sopnea, DSAT. BB is fine. Saturation is 88 only. And GVB is high. Past medical history is very important. In order to, he was 16 years old. Now his age is 38. When he is 16 years old, he got shot to the chest during bird hunting trip. شظية من الشظيات اتخبطت فيه. Right? While his friend was loading his refill. After that, he transferred to our hospital by Red Crescent, and he was management in ER by small, urgent surgical pericardial window. Very small pericardial window. And our surgeon at that time, he made 2 sutures in his RV without heart-lung machine. And he discharged for home after 14 days, right? The past history is mandatory. Local inspection, only the healed scar of very small window before, some moderate beating edema in lower limb, local examination, soft diastolic murmur in second aortic area, maybe same aortic regurg, band systolic murmur at the apex, which is referred to axilla. There means there is some MR. Band harsh systolic murmur in second and third left parasternal area. B2 sky high, and there is some ejection systolic murmur in the lower parasternal area, which is increased with inspiration. ECG left bundle branch block, plain X-ray cardiomegaly with lung congested. Always we make CT coronary angiogram in our ER, by the way, as if take coffee in the morning. CT has become as if coffee now. Echo, as if you can see here, you notice very damaged LV, desynchrony due to LV, dilated LV. I think it is damaged LV 20, 15 maximum. I can say here there is around maybe resting wall motion abnormality in the circ territory, if I can say. Even the two-chamber view, which is RCA territory, maybe some hypokinesia, as if you can see. Lastly, here, even the basal septum or inferior basal septum, there is something, it is, looks hypokinesia or something I'm not happy, honestly. Oh, color, there is same aortic regurg, maybe some TR, small MR. I make the pressure half time in aortic regurg is 650, which is not explain the aortic regurg severity and not explain the LV dysfunction. There is something, if I can make it here, the basal septum, there is something not happy. There is some small shunting, as if we make error here, like small shunt, VSD shunting. Oh, miserable. Aortic regurg, some big shunt here, VSD shunting, and there is mitral regurg. 3 mosaic jets. ER, some VSD I can say, and we'll go for TE then. Miserable, I cannot make it anything right. So damage LV very nicely here. I'm not happy by this area at all. That's why we concentrate the short axis. There is space here now between non-coronary cusp, and there is cavity here, and another small something cavity here, which is can be crossed to the LA. I make it magnified here, very nicely. Aortic root, space here, space there. Very nice. See? Even the tissue is disrupted here even. And remembers his past family, past history. I make it here again, VSD, aortic regurg. I make it magnified. See? Aortic regurg, some ventricular septum, some mitral regurg. See here? This is a VSD flow, right? And these patients have history of shooting gun. When you make Doppler, you can see systolic and diastolic flow. This meaning what? This meaning the shunting between the aortic root, not LV, aortic root to LA, right? It is not an systolic only, it is systolic and diastolic flow. Again, you can see here, there is some rupture or something here in the aorta, right? And I make there is shunting here, as if your airway says, and there is aortic regurg. So we want to let solve the case. There is perforation in right ventricle when his age is 16, which is surgically treated. VSD very nicely. Aortic valve, it is perforated, right? And shunt between aortic root and LA. If you want to make it simple, see this how the pullet is go from the RV to the aorta, make it perforation aortic root, and go to the LA. And here is transesophageal, and here is transesophageal. Again, approximately the same here, from RV to aorta, rupture or perforated, LA, and again from the same issue here. So from here, VSDs, and then go to the MR due to dilated LA. So this completed how the bullets is go. So the explanation of this issue is what? Where the bullet is. The bullet from 15 to 20 years, it is go from LA, which is a spontaneous sealed, and it is go for the end of the vertebral column. رشة العصفورة مش عارف انتوا عارفينها ولا لا. This my patients, right? Okay, nice. So So we push the patient for surgery, definitely. What is type of surgery? We'll go for aortic only repair, not aortic valve replacement. And we close the VSD, and the net result is like that, although the LV is not so improved. So the take-home message, please, take history is the key. Always the lateral X-ray in cardiology, everybody is missed. Lateral X-ray is important in most of our cardiology case. Sometimes we want to play puzzle to solve the medical mystery. And thank you very much.
يديك العافية دكتور أيمن. Thank you very much. I think it's a nice case. Important to take the old history. Any question? Comment? No? So الحالة كانت مرة واضحة قد كده. طيب ممتاز. يديك العافية دكتور أيمن. شكرا. So our next speaker دكتور حسن علي. He is the head of adult cardiology in King Abdullah Medical City, Mecca.
بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Thank you for the organizing committee for inviting me to this prestigious conference. My talk will be about eye on the heart and nothing to declare. This is the 14-year-old boy referred from Hera General Hospital to our ophthalmology center because of decreased vision. The ophthalmology seen in the clinic and almost lost vision in one eye, and the other one is very decreased. They did the usual test, and they find that also from the history, left eye blurred vision, and had right eye surgery and laser in early childhood. So he almost lost one eye, and the other eye is very reduced. This is the test they did, and on the fundus, what is there is flat retina with hemorrhages, and what is important is the presence of vascular aneurysm and other findings as well. And on the OCT, they find flat retina. They put their impression, and they did the basic lab test, including hemoglobin A1C level, and they referred him to cardiology for consultation, and they asked for an urgent echo. Also, they did some genetic testing, which we will reveal later on. In our cardiology clinic, he was seen in our screening clinic, 14-year-old boy, medically free, seen in the follow-up ophthalmology clinic, no cardiac symptoms before, and he is vitally stable. Examination is unremarkable, and his ECG is normal, and we reviewed also his previous labs, and they were all normal. We sent him for an echo, and his echo is almost normal, nothing major. Ejection fraction is good, and it was reported almost normal here, but the salient feature is that the pulmonary artery appears hourglass shaped and narrowed in the supravalvular region. And they recommended that we should do a CT cardiac morphology, and later on we may need an MRI. And this is the echo which showed the area of supravalvular narrowing. The case is called familial retinal arterial macroaneurysm, and this was first recognized by the Hinsa and Aboud in 2002 from King Khalid Specialist Eye Hospital in Riyadh. It is a familial condition, and there is certain characteristics or phenotypes which are present in the retina. Arterial beading and macroaneurysm along major arterial trunks, segmental arterial narrowing and sheathing, and persistent remnant of the hyaloid artery another syndrome which is coats-like features, and recurrent episodes of macroaneurysm, exudation, and hemorrhages, often leading to subretinal gliosis. So that is the reason why these patients lose their. In 2011, they recognized the gene which is responsible for this abnormality, and it is insulin-like growth factor binding protein. To date, there is reported about 30 cases, mostly of them in Saudi Arabia, and they are usually young. The age range from 1 year to 37 years, and mostly they are the result of consanguineous families and so on. So supravalvular pulmonary stenosis was recognized in almost all of these cases as part of their systemic evaluation. And this is sometimes change the name of the condition to retinal arterial macroaneurysm with supravalvular pulmonic stenosis. What is important is that further cases are identified, and there is an extended follow-up of these previously reported cases, and there is also more extensive systemic evaluation of these cases. And by this, they identified further features or further problems with these patients, including aortic valve, splenic and cerebral artery involvement in these patients. They did the follow-up for these 30 patients for almost 8.5 years, and all of them, they have the syndrome or they have this FRAM disease. And they expanded their clinical spectrum of this by finding other previously unrecognized major systemic arterial involvements. 4 associations were there. We said the pulmonary already, and then coexisting aortic supravalvular stenosis was described in 22% of the patient, splenic artery involvement in 1 case, cerebral vascular involvement in 3 cases, leading to stroke in 14-year-old and death in 1. And this is a case, interesting one, a lady at the age of 40, she was referred to King Khalid Eye Specialist Hospital because of visual decrease. And they confirmed the diagnosis. And what is important in this young lady is her past medical history. At the age of 29, she had a myocardial infarction, and at the time also she had left subclavian bruit. They did cardiac cath, and at that time she had significant LAD disease. And what is interesting, she had 2 macroaneurysms on the first and second diagonal branches, and her rest of her coronaries are normal. And this is where they show the aneurysm. She underwent CABG at the time. Interestingly, they did like a pan-CT angiogram, and they find total occlusion of the left subclavian artery, mild stenosis of both renal arteries as their origin, mild irregularities in the mesenteric artery, and tapering of the aorta when it reached the bifurcation. Luckily, the cerebral and carotid artery were not involved. So, in conclusion, or the take-home message, this syndrome can be associated with major potentially life-threatening coronary artery disease or systemic vascular disease, which must be recognized early. And especially these patients are very young, and we could see the age range is from 1 year to 37 years. Although a thorough cardiovascular evaluation aiming for early detection and management of these complications is crucial in this young. Likewise, in the other way around, if you have a patient young with some cardiovascular problems, it is important to send him for a retinal examination and the possibility of the mutation as well, especially if he's to complain of some sort of visual abnormality. So this is the take-home message we have to take. And thank you from Mecca.
Any question for Dr. Hassan?
What was the gradient in the stenotic area? Thank you.
I think I missed to mention in one of these. There is, I think it was found in 47. Ejection fraction is above 65. There's another patient from the family. There's a calcification here for mitral valve. Another patient, the same family. There's also hypertrophy for LV and RV. So, in the community and in the practical speaking, approximately 50% of the patient with heart failure presented to our hospital complaining from shortness of breath and the signs and symptoms of heart failure have the ejection fraction more than 50%. So this number, it is not low. This is not 5, it is 50% come with heart failure with preserved ejection fraction. The problem, the patient with heart failure was preserved ejection fraction. Heart failure was reduced ejection fraction. It is easy giving the medication, interest like that, and the patient is improved. The problem is the patient always searching for the problem. Nobody can treating them because normal ejection fraction is normal. So there's resource utilization, and also the patient is always symptomatic. There's many causes for differential diagnosis for heart failure with preserved ejection fraction. Today I will present one case. It is a Fabry disease. Fabry disease, it is a lysosomal storage disease. It is an inborn error for metabolism of glycophospholipid metabolism due to deficiency of enzyme, lysosomal enzyme alpha-galactosidase A. This enzyme is responsible about the metabolism of glycophospholipid. So if it is a deficiency or absent, will be accumulation of glycophospholipid, which can be accumulated in the renal, in the kidney, can be also in the heart, skin, and the brain. The problem also, glycophospholipid cytotoxic, in addition to infiltration, and the problem, and can causing cardiac, can causing end organ damage. Also, it is cytotoxic, pro-inflammatory, and pro-fibrotic effect also. And it is responsible about the arrhythmia in the patient with Fabry disease. And Fabry disease can affect the myocardium, causing hypertrophy, and causing restrictive, and this is one of the cause of restrictive myopathy and the shortness of breath. Also can affect the conduction system, causing bradycardia, bradyarrhythmia, and even heart block. And sometimes the patient with Fabry can present with VTAC due to fibrosis in some patients, due to glycoprotein accumulation. Also can affect the valve, causing mitral regurg, aortic regurg, or even stenosis. So the Fabry disease, it is lysosomal disease. Affect kidney, causing proteinuria and renal failure, affecting CNS, causing TIA and causing stroke, can affect the skin and causing burning sensation and angiokeratoma, also can affect the heart. The Fabry disease, it is one of reversible disease. If you discover the disease early, you can treat the patient and prevent cardiac damage and renal damage. So the diagnosis is very important, and there is now available replacement therapy for Fabry disease. But must be diagnosed early as you can before damage. It is angiokeratoma in the patient with Fabry disease. One of the family also, not the first wish, one of the family was mitral valve and aortic valve replacement. Mitral and aortic mechanical valve replacement in patient with Fabry disease. Also, a pacemaker, epicardial pacemaker. And this type of patient presenting also with bradyarrhythmia and heart block. So the echo, this is the most common diagnostic tool. Why I present this case? To searching for the heart failure with preserved ejection fraction. This is very important. Why very important? Because if you come, so next slide, please.
I screening more than 10 patients from the 10 persons from the family. 25 years old girl became, to be fair, not symptomatic. Looking for here. I searching here, there's a second for posterior mitral valve leaflet. Looks infiltration, I would say. Korean now. There's infiltration for posterior mitral valve leaflet associated with mild to moderate mitral regurg. When I found that, it is most probably, it is not traumatic, this valve, it is not maximitous, but from the history and from the echo finding, it is a simple way, it is diagnose this patient. I send the patient to the treating physician for enzymatic and genetic scan. After 10 days from this female girl, presented one in ER complaining from dizziness, fainting attack. But ECG must be done for everyone. They found LVH, this acute coronary syndrome for them. Calling me, this young, about 25, ECG, this LVH. Ask him to auscultate the patient and no murmur. I keep the patient the second day, normal bone motion, normal left ventricular function, and the patient has LVH also. So must be awareness about the heart failure with preserved ejection fraction. Thank you.
Okay, thank you very much, Dr. Ayman. يعطيك العافية. I think it's very important to look for the Fabry's disease. Especially now we have the diagnostic tool. And in the matter of fact, one of the company, they offering to do for you the enzymatic assay and the genetic for free. So you only, they give you a slip like, you get a brick from the blood, put it in that frame that you have it, they send it to the company, and really the company get back to you. I have experience with the patient, so I encourage you really to utilize these resources. Any question? No? تفضل دكتور حسن.
تفضل يا باشا.
Yes, it is important to catch these patients as early as possible. Now the treatment is available, although it is very expensive, but it is available and it is very useful. I have one case I think shared with Noor Hospital, but already now he is on treatment and he presented with atrial fibrillation in his 25s or something like that.
I do this patient about 2 weeks. I sent already for enzymatic, but in female better also to genetic in females. But enzymatic one. Now she is proceeding for genetics screening now.
Okay, يديكم العافية. I think it's very important. Please utilize the resources. So we'll move to the next speaker.
Our next speaker is Dr. Abdurrahman Jamil. He's here. He is consultant cardiologist and assistant professor at King Saud bin Abdulaziz University for Health Sciences. Dr. Abdurrahman, welcome.
Assalamu alaikum. Thank you, Almoosa Hospital. Thank you, Dr. Ala, for invitation and present my case. So because our audience are mixed, pediatric and adult, so I choose something in between adult and pediatric. So my patient is a 15 years old boy. I have seen him in my clinic with shortness of breath, some murmur, and lower limb edema and some clubbing. So I'm very classical man. I will start with the M mode. Cannot escape it. So, and I need some interaction from the audience. What do you see in the M mode, especially fellows? So because of sake of time, I will just answer. So since this is mitral valve, so this is the interventricular septum, and this is the RV and LV. So what we notice, the RV is quite dilated compared to the LV. But what is this one? To know this one, we go to the this view. What happened? What happened, Shabab? زمنا وقف الزمن عبد الله كيف حالك؟ Okay, so to know the, what is that one? This is a prominent modulator band, okay, get in the M mode sometimes, severely dilated, hypertrophied RV and small LV cavity. So can شباب can نشغل أيوة okay. So D-shape LV, severely dilated RV, again in the apical 4-chamber view. In this view, we see we have moderate TR and very high, sky high RVSP. If we add 15 or 20 RA, this will be like 140, 150 PA pressure. It's very, very high. Again, in the apical 4, we see compressed, very small LV, very small LA, and again confirm our finding. So based on this finding, what is our diagnosis? Is it TOF? Is it double chamber RV, pulmonary hypertension, query cause, or no idea? I think obvious pulmonary hypertension, sir? Pulmonary hypertension, okay, we'll see. So pulmonary hypertension, so what are the possible causes? Is it congenital mitral valve disease? We have seen the mitral valve is quite okay, it's quite normal. Is it coronary atrium? We don't see any membrane, anything. Is it pulmonary stenosis? We see in the next slides, okay? So is it Eisenmenger syndrome? Possible. Or something else, we'll see. So this is RVOT, quite normal pulmonary valve. Don't think there is any PS. And this confirms the high pulmonary arterial diastolic pressure. So this is again, goes with severe pulmonary hypertension. When we look closer to the RVOT, we started to see this flow. So what is this flow? PDA. PDA. And the Doppler, what Doppler shows? Bidirectional flow. Bidirectional flow, to and fro, okay, up and down, okay? And even by color we can see it, okay? And this, what we call it ductal view. We don't do it in adult very much. So I will explain to people, this is aortic arch, sending thoracic aorta. This is dilated pulmonary artery, especially left pulmonary artery. And we see again the flow to and fro. This is bidirectional flow. So this is PDA, no doubt. So based on, so far, what is our diagnosis? Is it, again, congenital mitral valve disease, coronary atrium, pulmonary stenosis? What is it? Or Eisenmenger syndrome? Eisenmenger syndrome? Okay, so Eisenmenger syndrome, makes sense. It is very logic with this PDA and bidirectional flow. So Eisenmenger syndrome is due to the left-to-right shunt. Then with time, there is a high resistance across the pulmonary valve or pulmonary artery. This will lead to severe pulmonary hypertension by directional flow, and later on, eventually, we'll have right to left reverse shunt. This is Eisenmenger syndrome. So far, everything goes with this diagnosis. But the thing is, Eisenmenger syndrome, to develop, you need like 20 to 40 years. If this is before tricuspid valve, the lesion before tricuspid valve, ASD or partial anomalous of pulmonary veins, and you need few years before developing Eisenmenger if this is VSD PDA. So having this information, I will show you the next slide, you will see. So this echo, I especially didn't remove the date. This is at day 1 of age. So already the RV is dilated, the LV is small. Again here, we see hypertensive RV and severely dilated RV, and you see the PDA, our PDA, and you see it's bidirectional flow from day 1. Okay, we see this is at 2 months of age, very similar to our 15 years old, the echo. So this patient has, from day 1, he has severe pulmonary hypertension and with bidirectional flow across, you see, very clear, bidirectional flow from day 1.
So what is the cause then? We said Eisenmenger needs time. But this patient, from day one, he has severe pulmonary hypertension. Any thoughts, any idea? Or I will go just for the sake of time, I will go. So to answer this question, we have some, استعانة بصديق. We will use other images. Okay, I know this is echo, but you see this X-ray at day one. What do you see in the X-ray? There is discrepancy between the lungs, two lungs volume. See in the left side, it's very small. This is at 2 months of age. Very clear discrepancies in the lung volume. The left lung is very small. Then this is CT chest at 2 months. You see, very clear difference in the lung volume between the left and right. And this is a coronal view. You see again the right lung, how developed. This one underdeveloped. And you see the heart is very huge, especially the right side. So our diagnosis here is already, I answered it, the question. We have, this patient has congenital diaphragmatic hernia, causing a compression of the left lung, very small, okay? And when the baby born, immediately after birth, the lung will expand, the pulmonary resistance will fall, and then the PA pressure will drop also. But in this patient, because he has very small lung, the pulmonary resistance didn't fall because he has hypoplasia of the lung, and he had what we call congenital, the persistent pulmonary hypertension of newborn. So this patient has congenital pulmonary hypertension, grown up with pulmonary hypertension due to congenital diaphragmatic hernia. Because all through this defect, all the abdominal contents will go up to the lung, compress the lung, and this patient will need ECMO at birth, need a lot of resuscitation. So this is a congenital, it is a large diaphragmatic hernia, usually presents at birth in the first few minutes or hours of life, is respiratory distress, cyanosis, decreased breath sounds. On the affected side, okay, displaced heart sounds and scaphoid abdomen. The respiratory distress can be severe and may be associated with circulatory insufficiency requiring aggressive resuscitative measures. Yes. Okay. Okay, خلاص أنا finish. خلاص. On time. Okay. Thank you very much.
Thank you very much indeed. Interesting case. Any questions for Dr. Abdurrahman? Yes, please.
Yes, actually, this patient had already repair of the hernia. But he has already irreversible pulmonary hypertension. Unfortunately, he died just 2 years back.
Oh dear.
Immediately after I seen him, I think
Next
maybe I'm the cause.
Okay.
I'm the cause of this.
You managed to get the case for the presentation.
Yeah. Okay.
From your review, do you think this can be reversible at any time if it's corrected early?
Well, I think so. I think so. Depends on the degree of the because initially you have physiological spasm, something like that. Okay, then later on the patient will develop fibrosis. So yes, established. If he develop like what we have in portal hypertension, for example, we have seen these cases a lot. Okay, so
okay, we have one question there.
Yes, please.
Before we make a diagnosis?
Well, I don't think right heart cath will add much because already we have all information. We have very severe pulmonary hypertension by echo, and we have the bidirectional flow. We have very clear PDA, I don't, but pediatric here can comment anyone from pediatrics.
Is Dr. Rima around?
I'm asking this
No.
question because I am concerned about the size of the left side heart chambers. The left atrium, the left ventricle looks small. So this
Yes.
PDA looks like not significant shunt. I think it causes
No,
not
if-
significant shunt.
If you see the ductal view, it is quite significant, quite this one, and it is clear bidirectional flow to and fro. But anyways, okay.
Yeah, but how often actually PDAs cause Eisenmenger?
Yeah, that is why, because in the presence of this pulmonary hypertension, actually PDA, it will lead definitely eventually to Eisenmenger. That is why our pediatric colleague, they recommend to close PDA no matter what the size is. Even if it is small, they should close it. If you see PDA, close it.
Okay, thank you.
صح يا شباب pediatrics.
Okay. Any more questions? Just last question? No.
Sorry. So regarding this case, the pulmonary hypertension is not because of PDA. Actually, PDA he is beneficial, and it was the reason to keep him alive at the vent. His problem is the abnormal lung, which is hypoplastic lung. So
Exactly,
yeah, yeah.
exactly.
Yes,
That's what my feeling, because I
Yes.
don't think actually such a PDA will
No, it's not,
create all
no.
this problem.
Exactly.
Particularly, this is from first
Exactly.
month.
From first, yeah.
So it's very
Yeah.
unlike.
So
Absolutely.
PDA is vent for his RV to
Yes.
keep him alive. Yeah,
Well
thank
done.
you. Thank you.
Okay, thank you. Okay, next. Thank you, Dr. Rahman. Thank you.
يديك العافية. We'll move now to the next, Professor Faiz Al-Sha'ir from King Khalid University.
Assalamu alaikum wa rahmatullah. This is not working? Okay. Vegetectomy. What is the meaning of vegetectomy? It is now we're back to adult and management case. So vegetectomy is excision of vegetation. Can we do excision of vegetation? Let us see how we can do this for that case. No disclosure. This is a 41 years old lady. She did the gastric bypass surgery. And actually, when we asked her, it was just she mild obese, and she did it for not strong indication. And when you do something which was not strong indication, you will have a lot of complications. Now she's complicated by internal hernia, which lead to small bowel resection and perforation. It started in home TPN in 2017, and she's hypertensive on medication, and depression definitely, and she developed pulmonary embolism and received rivaroxaban. Her echo on July 2021, it was normal, absolutely normal. Okay, she came to the hospital with an infection, MSSA bacteremia, in August 23. So echo done, TE done, large vegetation, high risk for azation. This is her echo. This is transesophageal. You see the vegetation on the tricuspid valve. Okay. This is in another serial echoes, the same vegetation. And this, it is high risk for embolization. Okay. So in length and 2.1 centimeter. So this is very high risk. What to do with this? It is getting larger, but the valve is still preserved, not damaged completely, and not significant regurgitation. So what we discussed this case in our meetings, and what to do. The three options here for management is either to give an antibiotic for proper doses and a course and for 6 weeks, or just go for some sort of dealing with this vegetation, either vegetectomy or what else. Okay. So antibiotic, yes, we know that the microbiology is very important. Since virulence of the infecting organism can be detected and can be managed, and we have to give strong doses of medication and a combination, high doses, bactericidal and prolonged. So managed with a course of IV cefazolin require CCU admission. But during hospitalization and during her course in CCU, she developed a lot of complication and expected. This is an acute pulmonary edema, acute renal failure, thrombocytopenia, and anemia. So we have to have another option. It seems that the antibiotic is not effective and we have to go for another option. Is this patient indicated for surgery? Yes, because it is major, large vegetation, and she developed congestive heart failure, and she had 2 indications for surgery. So we discuss with the surgeon and we refer our patient to surgeon. As usual, the surgery will be some sort of resistant. He needs the patient to be hemodynamically stable at the time of surgery and need 2 weeks of antibiotic. So the case was declined by the surgeon as she was mixed cardiogenic and septic shock. So they said, no, we'll not do with this, continue with your medical treatment. So the case again was discussed in the heart team, and the idea came up with our intervention that we'll have to go for vegetectomy via interventional, via catheter suction of this vegetation. And there is an evidence of that in the aortic valve, and it was done without damage, sparing the valve, and the valve was okay. And it was also done in, as this case reports is not that strong, an atrioventricular valve and mitral aortocuspid valve in the drug addict. And this is a way of angiovac using it. It is like some sort of veno-venous bypass circuits. Less invasive. Doesn't require cardiopulmonary bypass, and it has a certain technique. It is very successful, 90%. In that case, a resolution of bacteremia within 48 hours, and 75% of case. Tricuspid regurg was not that significant. This is articles. So the she was planned for vegetectomy, okay? And the day of catheterization, and everything was ready, she went to the cath lab, and during the cath lab, just before we searched for vegetation, it is dissolved without anything, with the medication. So this is the one. Yeah, this is the vegetation here. It's getting less and less, so we are very happy, especially all the type consultant who are just on all the classic ways. But the new generation, they like to do and to interfere, and we need to see the result of that, such methods. Okay, and this is her aortic valve after management of 6 weeks of antibiotic. So complete 6 weeks of antibiotic was completed and discharged home for regular follow-up. Her last TE, she did a lot of TEs. Her last TE was normal finding. Then she came again on 29 of December 2023. Okay, she had the back line, and this back line was obstructed, and then we took culture from that back line, Staph aureus and Acinetobacter baumannii, and started an antibiotic by ID and admitted to the hospital. So microbiology in 26th of December, it was Enterobacter for urine, it was Staph epidermis for blood culture, it was Staph hominis or antibacterial, some antibiotics, and on 2nd of January 2014 was negative. So she started an antibiotic, vancomycin and ceftazidime. TE was done because requested. We know this patient is high risk for everything. And this is her TE. You see something in the aortic valve. There is an echo-dense structure, thread-like, highly mobile, attached to the leaflet. And we thought in that situation, this is a vegetation, another vegetation, but now this time in the aortic valve. You see this one, this echo was done after an antibiotic, also given for 6 weeks. And it looks that it becomes the same. Backline was exchanged, rivaroxaban was held for completing 3 months, and started on enoxaparin afterward for prophylaxis. So what to do with this? Repeated echo again, many times. 6 weeks of antibiotic of vancomycin and ceftazidime was given, and this is the echo again. This is the transesophageal echo. The mass is still there, almost the same. And when we go back to the echoes, all the echoes, we found the mass is almost the same before, and we review it all one by one. This is different imaging. You know, the people are fan of imaging, so you do whatever you want. Okay. still there. And then we decided patient given 6 weeks of antibiotic, and she was discharged home. This is a tricuspid valve we want to show you. Tricuspid valve, again, we don't have any recurrence of vegetation at that valve. So the mass is almost the same all the 3 weeks, the 6 weeks, and then complete course of antibiotic, and patient discharged home to home health care. Upper GIT surgery informed for follow-up, and Rivaroxaban was discontinued. So the take-home message is here. First, unnecessary surgical procedure should be avoided because nothing without price. Surgery, you might have complications. Relapse should be avoided in patient with infective endocarditis by giving proper dose, proper course, and duration. Vegetectomy is a way of invasive management of infective endocarditis. When surgery is prohibitive, you can do, but there is technical issue and need people to be trained. Effective antibiotic regimen can be managed, large vegetation, and can be dissolved without damage of the valve, causing abscess or perforation or whatever. And heart team discussion, and repeat echo frequently every 1 or 2 weeks in case of infective endocarditis, and patient should be on the hospital. This is Duke 23. This is a new era of new criteria. Microbiology, no need to separate. Separate blood cultures, and you can go for imaging, and all these criteria you can review. Thank you.
Thank you very much, Faiz. I think it was a challenging case. It's very important really to have a high clinical suspicion and appropriate intervention at the appropriate time. And detailed echo is always necessary in such cases. Questions?
Thank you for the interesting case. Now, the tricuspid vegetation was convincing, but the aortic is not. The size, the location, the echogenicity, and all of that is not like matching the typical vegetation. Besides, patient of nutritional deficiency like that, they might have enhanced degeneration. This might be part of degeneration. So I would have done PET to confirm, maybe. I don't know what you...
I agree with you. This didn't look vegetation, and it is proven that it was the course of management. Does it change all through? And when we review all the echoes, it was the same. But in clinical situation, patient came with fever and had multiple cultures, and she had just discharged from the hospital with a large vegetation like this. So we followed her up, and we found that it is not like vegetation. It may be like Lambert's excrescence or fibroblastoma, or however it doesn't look. Usually the vegetation in the LV cavity, not on the aortic side. So I agree with you totally. But patient improved, so no need for PET scan. However, the PET scan is one of the major criteria now for the diagnosis of infective endocarditis according to Duke. Yes.
It was the same question.
Yeah, I agree with Hatem. Now PET infection actually is class 1 indication, especially in these doubtful cases. I remember just last week, we have a patient who had bioprosthetic AVR, blood culture positive, but is not the typical organisms. We did, TE, there is no vegetation, no abscess, nothing. So it doesn't fit the criteria for definite endocarditis. So we did PET infection, and there is very clear activity around the bioprosthetic valve. So we treated him with 6 weeks antibiotics. We repeated the PET infection and came negative. And the TE, again, we repeated it also negative. So
there was no vegetation. There was no vegetation.
No vegetation, just based on this PET infection. Now it's class 1. So it's very important to do in this borderline cases, doubtful cases, we have to do PET.
I promise you next time, because she will come again after 2 months with another vegetation, so we'll do PET for confirmation.
I think we'll stop here. We have to move to the next speaker. Thank you very much.
Thank you. Promise.
The next speaker will be Dr. Tariq Al-Hussein, consultant cardiology, cardiography, and interventional echo at Johns Hopkins Aramco Healthcare. Dr. Tariq.
Assalamu alaikum. So I would like to really thank the panel and the Almoosa Hospital for this great conference, and special thanks to Ala for his great organization and welcoming. So I'm Dr. Al-Hussein. I'm a cardiologist with interest in echo. I'm going to present an interesting case. So there is a lot of doubts about this case, and I would like also to hear your views about that. So I have no disclosures pertaining to the content of this presentation. So I'm starting my presentation with a 47-year-old lady. That lady is actually from the southern part of Saudi Arabia. She's a very pleasant lady, very humble. She's a widow, and she has an orphanage home, and she's taking care of orphan kids. And she has no significant past medical history. However, for the last 6 months, she had a progressive course of shortness of breath. That was unclear etiology. She visited many primary cares, many hospitals, and they didn't figure out what's going on with her. Some people, they attributed that to physical deconditioning because she was a little bit obese. However, when we saw her in a hospital, our colleagues in primary care, they've done their basic works. Nothing was there, actually. And they did a chest X-ray, and there was a cardiomegaly. And whenever you see cardiomegaly on chest X-ray, what's the next step? It's echo, always. So a transthoracic echo was done, okay? And this is the pointer here. As you can see, this is the left parasternal short axis. So you can notice some mitral regurgitation is there. Valves are somehow thickened. Okay, the left atrium is big, and there is something here. So wondering, is that an artifact? Is it a membrane? So we'll see with successive views. So this is the right atrium, septum. Probably that's the Eustachian valve. A more focused view can see that there is something there, okay? So is that an artery? Is it a cavity? So it's not really clear what it is. Going forward, so any thoughts about this view? So that's the IVC here into the right atrium. That's a more focused view. On the right side, we see the septum. Yet nothing looks abnormal apart from a little bit of TR. But there is something abnormal there, something very weird there. Okay, that's flow with an abnormal direction. So going forward, again, that's the mitral valve. And as we look here, okay, the valve, as we said, mentioned earlier, is thick. There is an MR, okay, and probably that's the LV cavity. And there is something really weird here, okay? Is that a true membrane? Is it an artifact? So there is looks like another compartment is there, okay? And by looking here and just tilting the probe from the apical 5-chamber to the apical 4-chamber view, you see the MR, and you can see clearly a cavity there with an abnormal flow. So just before going to TEE, did anyone can make any conclusion from that? What is it? Any thoughts? Can you make up a diagnosis? Supramitral ring.
Can I say, or I'm going to spoil it, this is Dr. Safa.
I don't want you to spoil it. So Dr. Safa, probably she might screw it up. So let's wait for the discussion to the end. Okay, so we did a TEE because there is an abnormal flow, and we would like to figure out what's going on. So we did a TEE, and as you can see here, so if you look here, you see the left atrial appendage in one view. By tilting the probe, okay, you see another cavity behind that, okay? That's your MR, okay? The mitral leaflets are thickened. There is some billowing, indicating some degenerative mitral valve disease is there. There is a significant severe mitral regurgitation, but again, there is something here, okay? So that something is anterior to the left atrial appendage. There is flow through that cavity, okay? And as we go further, okay, so that's the right side, okay? As you can see here, the septum is intact, Bicaval view, nothing appears there. Going forward with more focused view, just pay attention here, okay? Just to the left of the aorta, you can see that cavity, okay? There looks like a communication there and there, okay? It's there, there is a hole there, okay? And here, you can see two distinct flow. So that all is a sac or a mass. That's like a membrane. There is a flow within the compartment of that sac, and there is a flow from an LV into that cavity, okay? So we had to scratch our head like, what is it? So as you can see, there is a clear communication. Whenever you see clear communication like this, you think of pseudoaneurysms. Pseudoaneurysms as a result of MI. That patient did not have any heart attack in the past. We did a coronary angiogram. She had a beautiful coronaries. Okay, her ECG did not show any Q waves. Is it a pseudoaneurysm of endocarditis? We did extensive workup, okay, to rule out endocarditis, and nothing was there. Okay, and we ended up with this abnormal flow and severe mitral regurgitation and that degenerative mitral valve. So that's in 3D. Just will give you a hints up. That's the mitral valve, the septum, tricuspid valve. That's the aorta. To the left of the aorta, anterior to the mitral valve, that's your cavity. And within that cavity, there is a hole there. So that's the hole where you saw the flow from the LV sides. That's the communication between the LV and the sac. This will show it more and better, okay? So that's the mitral valves, that's your MR, and that's the forward flow that's coming from the LV into the sac and through that membrane, which is that flow. So we had an extensive discussion in the heart team, like what is it? Okay, so as we mentioned earlier, the patient had normal coronaries, no ischemic heart disease, no, we thought of endocarditis. We've done PET scan, we've done MRI, we found nothing to point toward inflammation. Okay, so we concluded up that this patient has, that this patient, what is this? What? You ended up the presentation. Just the same cavity with the same hole. PET scan did not show any points of inflammation. Huh? What type of answer you will be looking for? Okay. This is against my time so far. So I will mention it just as the case forwarded, and later on we will open the discussion. Okay, so the 3D, we talked about the 3D, we talked about the color in 3D, and we had a heart team discussion like what to do with that lady, so we ended up with the conclusion. She had a symptomatic severe MR, she has a borderline EF, she had a mass pseudoaneurysm by description that needs to be fixed. Is it infective endocarditis versus fibroelastic disease involving the mitral annulus, a rare entity, but it could be the case here. So the decision was to take her and do cardiac surgery. So the patient went, she had an MVR, and the input from the cardiac surgeon that it was a very lengthy surgery, okay, and the tissue was very friable, okay, and very flimsy, the annulus, and it gave them actually a hard time inside the OR, okay, to be able to suture the valve. When I did the first transthoracic echo, what you can notice from here, there is some rocking motion of the valve. So I was not happy about the motion of the valve, okay, and the way it moves, although with color, there was nothing there, okay? There was no paravalvular leak. We did a TEE. It confirmed no leak, but the valve motion, it doesn't appear to be stable. So we had another discussion about what to do about that. So because the surgeons, they had a hard time with this patient, and they didn't want to consider going back into the OR. It took them 13 hours to fix the valve and to suture it in the ring. So we said, let's watch this patient and how she's behaving. So she had an uneventful post-operative course. She stayed in the hospital for 2 weeks, discharged home, and we followed up her multiple times. Within 3 months post-discharge, she was doing very well. Later on, That's again the post-op echo. Okay, you see the valve what I'm talking about. Okay, and you see how it's moving. As I said, there is no regurgitation, and the mean gradient was acceptable. So 4 months later, she came to the clinic. She had a progressive shortness of breath. Okay, 1 minute. Okay, so she had a progressive shortness of breath. She dropped in the ER. She was hypotensive. Her ECG showed A association. We admitted her to CCU. We've done a TEE, and now you can see the valve very clearly unstable. Okay, now you see a very thin, if you look at the tissue characterization here, that points toward an infectious process, okay? So now here, again, the valve is not stable at all, okay? It's rocking. There is also some dehiscence here, as you can see, and now we see paravalvular leak that was not there before, okay? And the valve is completely unstable. So based on that, we looked, she had AV dissociation, so we suspected a root abscess. We didn't see that, but again, there is an abnormal tissue characterization in this area. So it may point toward an early abscess formation, and that's your paravalvular leak. And again, there is a pseudoaneurysm there. So I asked the surgeon, like, what did you do with this lady from the start? So going back from the LV side, still the flow is there. Okay, this is the LV, okay, from the LV into the cavity. That's your paravalvular leak, okay? And the surgeons, they say, we fixed that hole, okay? And I don't know really to say, so probably it opened up again. So it was a very difficult, lengthy surgery from the beginning to start with. So the patient, we decided to transfer her to a higher center. We transferred her to Riyadh, King Faisal Specialist Hospital, and she's still admitted until this moment. Okay, Dr. Zuhair Hillis, he reoperated on her, and they had to reconstruct the whole base of the heart. And as per his feedback, that this case is the second case he saw in his life where they have like a very thin, abnormal mitral annulus and tissue characterization, and he do believe that she has some elastine disorder in the fibrous, and it was infected at that time. But going back with the case from the beginning, we did all the workup, and it didn't show endocarditis. So I brought it here for any thoughts and also for your opinions as well. Okay, so we have 3 minutes for discussion. Dr. Haliba.
Lady doctor here.
Dr. Safa كانت متحمسة جدا. I was about to jump here. So let's see her.
Assalamu alaikum. I come all the way from Dammam, Al-Mana Dammam, where we had the pleasure of looking after this lady on her first presentation. She came with a catastrophic crashing pulmonary edema, which was not quite evident at that time why she was in pulmonary edema. And the LV function was okay. And to be honest, that's the main lesson. This mass, which was seen in the left atrium, which we were not sure if this is an artifact or not, it was there from the very beginning, but it escaped our observation. The reason why she was actually came under our care is that because I had to TOE her to look for the mitral regurg. And it wasn't quite large mitral regurg at that time, but there was this mass with this communication. We didn't know what that mass was. And then we referred the patient for cardiac MRI, Abdurrahman, just to get your confidence back. There was a huge pseudoaneurysm at the LVOT. It was the hugest LV aneurysm I've ever seen with a classical description of MRI on a pseudoaneurysm. So we referred the patient for angiogram, classical nice angiogram. So we handed her to the team. She was a JAHA patient for pseudoaneurysm repair.
Atrial functional TR, anterior leaflet problem, is it all of these? And where is the jet coming from? Septo-anterior, septo-posterior, anterior-posterior. And what is the intervention of choice, surgical or transcatheter? I will go directly to the answer. So this is a atrial functional TR, and the jet mainly septo-anterior, but there's another jet coming from septo-posterior. And the best intervention for this is transcatheter or percutaneous, because she's old with multiple comorbidity. So this is our report. 2 jet, 1 major jet coming from the septo-anterior with a gap of 0.8 millimeter, another moderate coming from the septo-posterior, the right ventricle dilated, function preserved, annulus is dilated. So discussed in our combined meeting, because of comorbidity, she's not for surgery. So a patient given referral to Bin Sultan Cardiac Center, Riyadh, and accepted for TIR. It was done by the TIR team, Dr. Hatim and his colleague, Dr. Sundus, and regular follow-up of the patient. Patient showed significant improvement of her symptom. The report she brought that she has successful 3V clip, 2 Pascal, residual moderate TR with a gradient of 3. And this is the echo on the follow-up in the clinic. RV look happy, and you can see the 2 clip. One, and there is like a moderate TR jet. And we are happy, and the patient happy, and we clear even the RV improved, the RV function improved, we see the TAPSI, and the PAP improved to a reasonable. But according to her, she came to the ER after 2 months after she sustained major chest trauma. She fell down in the bathroom, and she visited Al Babtain Hospital ER, and they did for her suturing, and she came to our dental clinic. This is the note of the dental clinic: bruising on the face, lip, swelling, suture. Yes. Oh my God. So this is a clip. You can see the RV. This is the lab. Nothing to report. LFT is still normal, and we did for her TE. One of the clip is the most anterior one is moved from its place, and this is the posterior leaflet. It seems that maybe it was discharged from the posterior leaflet, and there is significant now TR, massive TR. So what will be the next step? This is atrial functional TR. So mortality is high. It affects LV, RV, and this is the new classification of tricuspid valve. And the atrial functional TR, there is 2 related to the LV side, or atrial because of atrial fibrillation. Here the RA dilated more than the atria. The annulus also dilated, and the LV because of afterload problem. And this is the new classification of the add massive and torrential TR. So the best treatment, medical treatment, and surgery. Repair is better than repair better than replacement. And
okay, I think Jazakallah khair. Thank you very much indeed, Dr. Rashid. Beautiful slides. It's pity that we could not see them all. Thank you very much. Any questions, please, from the audience? Yes, please. Sorry.
Yes.
So there is plenty of the posterior of the septal leaflet. So this is more of ventricular TR than atrial TR.
Yeah. Because we follow this patient since a long time, and the 2019 she has echo, showed only moderate TR. Because of the severe torrential TR, which is prolonged for a long time, the LA dilated and the RV start to dilate. And it is actually combination, atrial plus some functional, but the main is atrial functional TR.
تفضلي.
Functional MR, because I've seen the repeat echo after the clip that the atrium is now dilated. So do we know if there is a cross between the two sides?
Yes, I don't know why the tricuspid, only the RA affected more than the LA. We noticed that in the area of the tricuspid clip, patient chronic atrial fibrillation, we noticed that the RA dilated more than the LA, and, but in this patient, the MR is only mild to moderate. And this caused all the sequelae of the problem.
Okay, well, I think if there are no more questions, thank you very much, Dr. Rashid. We'll move on.
Just to follow up with this patient, after this event, we sent a report again to Prince Sultan Cardiac Center, and she was accepted for trick valve, which will be done tomorrow, inshallah.
Very much.
Or after tomorrow.
So we'll move now to the next speaker, Dr. Huda Shahata. She's a consultant intervention echocardiography at King's College London. Dr. Huda.
So, good afternoon, everyone. Thanks, Dr. Almoosa Hospital and the organizing committee for giving me the opportunity to present another case this year. So, my case today is named 2 arrows, just in case. I have nothing to declare. Our gentleman is a 57 years old man, presented with shortness of breath. He has an ejection, systolic murmur here over both aortic areas. So, despite that we do not have a good transthoracic echo window, but here we can appreciate that we have a heavily calcified aortic valve, normal mitral valve, normal left atrial and LV size. And here we can appreciate by the color flow, we couldn't see any significant aortic regurgitation and no MR. And then here in the apical 4-chamber view and also in the apical 3-chamber view, we can appreciate that we have heavily calcified aortic valve with restricted motion of the cusp with trace MR. So we measure the gradients across the stenotic or calcific aortic valve. We got like peak and mean systolic gradient of 85 and 60 millimeter mercury. And we calculated aortic valve area is 0.8 with LVOT diameter of 23 millimeter. So we went for 2D, 3D transesophageal echo to appreciate the morphology of our valve and to appreciate the function of this stenotic valve. Here we can appreciate in the left upper panel that we have a mild to moderate eccentric aortic valve regurgitation. We have eccentric aortic valve orifice with restricted motion of both cusp. In systole here, in the lower left, lower right panel here, we can appreciate that there is good opening of the aortic valve cusp in systole. So till now, we have mild aortic valve regurgitation, but we are not sure about the severity of the aortic valve stenosis. So we went to biplane mode here. We can appreciate clearly from the morphology that we have a unicuspid teardrop-like valve orifice here with restricted motion of one cusp here. And again, when we look at the morphology, we should choose the systolic frame to check how many raphe, how many commissures we have not in diastole. So we went to the 3D echocardiography here, zoomed view of the aortic valve. We are looking from the aortic, ascending aorta actually. We can appreciate that we have one commissure here at 12 o'clock and we have 2 raphe. So we have a unicuspid aortic valve area, unicuspid aortic valve morphology, and we planimeter the aortic valve area using the MPR and the biplane mode, and it came in the moderate aortic valve stenosis, not severe. So why we have here high gradients in this patient, despite that the area came in the range 1.1 and 1.2. So here we can appreciate that there is a crest or a calcific ridge seen inside the aortic valve when we went back here. So when we group, then we unroof the aortic root, we can appreciate that there is here a subaortic ridge or membrane is hidden inside the calcific aortic valve. So here again, we can see this ridge extending from the posterior annulus down to the edge of the aortic valve cusp. So our diagnosis is unicuspid aortic valve. In the echo here, we can differentiate with the conventional tricuspid aortic valve. In the echo here, we can differentiate with the conventional tricuspid aortic valve and the common bicuspid aortic valve by having single commissural zone of attachment with the rounded free edge of the cusp here and the eccentric valve orifice, like in our case. And we have two types here, unicommissural, like in our case, and acommissural type, which is less common. So in the unicommissural one, we can appreciate that we have a teardrop lateral orifice with a larger effective orifice area, and this comes with our case. And the acommissural type, we have no commissures and central pinhole orifice with more stenotic aortic valve. So regarding the valve function, the most common predominant valvular lesion is isolated aortic valve stenosis, could be associated with aortic regurgitation, but isolated AR is not common. Unicuspid aortic valve could present with severe alveolar obstruction in early infancy or severe aortic valve stenosis later on in life. So it could be associated with subaortic obstruction, like in our case, PDAs, VSD, or anomalous coronary artery. And the therapeutic options, usually in the young age, we go for aortic balloon valvuloplasty, but most of these options are palliative and associated with high risk of recurrence. So the most proper treatment for these patients is aortic valve replacement and treatment of the associated conditions like VSD, subaortic membrane, or PDA. So our take-home messages for today: congenital unicuspid aortic valve is a rare pathology causing aortic valve disease in young adolescents and adults. Usually its incidence is probably underestimated. 3D echo can observe the aortic valve from both aortic and ventricular aspects, assess the severity of valvular thickening calcifications, and we could do planimetry of the effective orifice area accurately. Earlier, surgical aortic valve replacement was the only therapeutic option, but now transcatheter option is another modality. And finally, our case was published successfully in the Echocardiography Journal 2 years ago with the team from Alexandria. And thank you so much.
The presence of value for this patient?
I don't have a lot of information about that. It's just according to the type. So the acommissural type is more associated with anomalous coronary arteries rather than the type with the two commissures. Yeah.
Thank you so much for the beautiful case. Since I'm a pediatric cardiologist, I just want to say, yes, it's underestimated. And you know why it's underestimated? Because there's uni and there's bi and there's tri. And there's also malfunctioning in the cooptation. So 3D helps a lot. And when even in the fetal life, I've seen bicuspid aortic valve. The question is that a lot of pediatricians don't comment on that. Yet in the adult life, this is one of the causes of aortic stenosis and one of the causes of not having full, I think, insurance coverage as well. And thank you. And I'm not aware of the subridge. I think it's not very common association.
Yeah. Thank you so much, Dr. Ing.
Thank you, Dr. Hoda. If there is no more question, thank you. We still have?
Just a comment regarding Dr. Ala's question. I think the prognostic implication of the raphe and which cusps are fused related to which part of the aorta can be associated dilated aorta, either the aortic root or the ascending aorta, and they can have an implication regarding the.
Thank you, Dr. Ali.
Thank you.
Okay, we can move to next speaker, Dr. Osama Abduraouf. Dr. Osama Abduraouf is a consultant cardiology in Birin Sultan Al Hufus Cardiac Center.
يقدم؟ لا مش محتاج.
لازم مايك عشان اللايف اكسترا.
بص اللي يقدم ده يركب. السلام عليكم ورحمة الله وبركاته. Thanks for invitation for this very impressive scientific activity. I will present case present. Okay. I will present case presentation who were faced in our center when decision is difficult. 65 years old Saudi female, diabetic hypertensive on regular medication, presented in the last 7 months by progressive shortness of breath. And in the last few days, she has attack of dizziness associated with sweating and fainting attack. She was brought to ER, in which initial examination was performed. Patient was conscious, alert to the person. Patient was conscious, alert, her vital signs was normal, and her oxygen saturation, blood pressure, temperature were normal. Cardiac examination revealed normal heart sound. However, there was some rumble, strange rumble, which looks like mitral stenosis at the cardiac apex. Chest was clear and abdomen was lax. ECG shows sinus rhythm, non-specific ST T-wave changes, and chest X-ray was normal. Blood chemistry, including cardiac markers, were normal. Based on the auscultation, transthoracic echo was done and revealed normal cardiac dimension, normal LV systolic function, ejection fraction 50 and 55. However, a large mass was seen within the left atrium attached to the mitral leaflet, and the patient was admitted to our center for further evaluation. This is what we found by her in her transthoracic echo. There is a large mass attached to the mitral leaflet. Actually, there are two masses, not only one mass, and it looks firmly attached to the mitral leaflet. Here, again, you can appreciate the two masses, and this mass is attached to the posterior leaflet. The other one is protruded in and out of the LV. This is zoom view again. You can appreciate that this big mass is fixed and the other mass is moving on and off. X-plane view, huge two masses. One is fixed, one is moving, and this mass causing significant stenosis of the mitral valve. That is why the rumble was heard during auscultation. As you see here, there is difficulty in opening of the mitral valve and acceleration of flow during diastole. In transgastric short axis view, you can appreciate that the mass occluding the mitral orifice, and this explains the fainting attack of the patient. Gradient was high across the mitral, and calculated mitral valve area was about 1.6. The mean gradient was 8. This is here 3D. Confirm what we find by the 2D. And here you can see the two masses and the narrowing of the mitral valve. And here you can see combined picture, 2D and 3D, show how big the mass is. Again, you can see the 3D and 3 orthogonal plane of the mitral valve and show the details of the mass. So, after this, many questions came to our mind. What is the nature of this mass? Shall we request any other investigation, CT, MRI, angio, whatever? So, this mass by experience should be removed. What will be the plan? Is it removal and valve repair, removal or valve replacement? What? So go to the first question. What is the first mass? Here we put some possibility. The first one, of course, was the least one, thrombus. A large thrombus, but this was not the usual site of the thrombus. Ejection fraction is okay. Patient in sinus rhythm, so no one voted for thrombus. Maybe mass. Second question, benign or malignant? If malignant, primary or secondary? If the mass is primary malignant, what will be our future plan? Anyhow, because most of us consider that it is abnormal mass and could possibly be malignant, we ask for CT to find whether there is any primary lesion in other area and this is secondary lesion or not. So CT and abdominal ultrasound was normal, coronary angio was normal, MRI was not requested because it will add a little, and anyhow the patient will send for the diagnosis and we will depend on the pathology for reaching the final diagnosis. So, one of our surgeon opinion is that this is a typical myxoma. Myxoma in abnormal position. And he has the hope that he will remove this mass and keep the native valve. Okay, this is good hope. But what if he removes the mass and keeps the native valve and the pathology later on came with surprising result? Anyhow, unfortunately, we don't have this here, okay? It takes times to even to get the normal pathology. So, anyhow, our surgeon have some hope, still some hope, and believes that it is a typical myxoma. Okay. Huh? Agree, okay. Time. Anyhow, we will open. We will see everything in the surgery and will manage accordingly. This was what the surgeon told us. Okay. At the time of surgery, I remember because I was with the surgeon, he smiled when he saw the valve for the initial impression and told me, you see, Osama, this is what I called you. This is a typical myxoma. Can you see this small yellowish part? This is myxoma. Now, I will try to resect the myxoma and keep the native valve. By time, it was very difficult to remove or dissect the valve, the mass from the valve. He tried too much, but he failed, even to dissect a small part, and he has to remove the whole valve. Usually, we are keeping the subvalvular apparatus during surgery, but at this time, we start to feel worried that this mass may be malignant. That is why it was removed by the subvalvular apparatus and cord tendini. And this is the mass. Okay? Large mass firmly attached to the valve, cannot be dissected, and when the surgeon removed it, removed by wide safety margin, including the cord tendini. Okay, the pathology came with high-grade sarcoma, leiomyosarcoma. Okay, primary cardiac tumor is rare, represent 0.001 and affect all group. About 75 cardiac tumors are benign. The minority are malignant. Angiosarcoma, rhabdomyosarcoma are the most common malignant primary cardiac tumor. اوكي why it's not working ليه مش شغال اوكي Leiomyosarcoma is mostly localized in the left atrium and usually invade the pulmonary vein. لا ده مش شغال خالص كده. The tumor is growing rapidly, have a higher rate of recurrence after removal. Prognosis is poor. Leiomyosarcoma is low has a low radiosensitivity. It responds poorly to radiation, and this is why the prognosis is poor. The chemotherapy is still the response to chemotherapy is less unknown. Okay, we saw a lot of cases in my
Dr.
life.
Osama? Time is finished.
Okay.
Thank you, Dr. Osama, for nice case. And this the floor now open for discussion or any question. Oh, Dr. Abdurrahman.
Thank you, Osama. Very nice case, really.
شكرا يا دكتور.
I enjoyed it. Yes. I think they should have done MRI because the best tissue characterization by MRI, myxoma will give you avascular, something like that. There's certain characteristics. MRI people are here can comment.
Yes.
But I think the law, by default, any mass, cardiac mass, MRI is a must, I think, for tissue characterization before any intervention.
Okay, agree. Huh? I will answer.
No, I wouldn't comment on MRI. I think on this case, it lacks from the very beginning many of the typical characteristics of a myxoma. It wasn't on the interatrial septum. I know it's not the norm for each and everyone, but it was away. Not only that, it was invading and occupying the left atrial appendage and traveling over. So this mass was quite suspicious and nasty from day one. So the likelihood of it being malignant was more than it being benign in the very beginning.
We have the same impression since we saw it. And personally, from the echo finding, the firmly attachment to the mitral leaflet makes me like this, okay? And when we consider maybe atypical myxoma,
I have cases like this at the base of the mitral valve, annulus and mitral valve leaflets. So there are cases like this.
Okay, for your comment, doctor, about the MRI, totally agree. But MRI will add nothing to the decision. Will add nothing to the decision. In every case, the patient will be sent to the OR, and we will depend on the pathology, not on the MRI. And finally, the MRI will never give you clear answer. He will write possible, portable, and so on. Okay? Will never give you accurate diagnosis.
Thank you, Dr. Osama.
Okay, for clinical correlation.
Thank you, Dr. Osama. Nice demonstration. We have to move.
And believe me, there is many MRI experts that can give you a very good tissue characterization. Thank you. The MRI was going to save the cell and all the trouble.
What it will add to the management,
Now he tells the patient, I'm going to remove the mass, save your fat. The consent will be different.
Okay.
Thank you, Dr. Osama. We have to move to next speaker by Dr. Basha.
Thank you. Okay, thank you very much. I think we'll move on. Our next speaker is Dr. Fathi Salim. I think it is going to be virtual, and I was told that it will be some time before we move. Is that okay?
Yes, sir. If he's not ready, we'll move to the next
one. Next one until he's joined us.
So we'll move to the
okay.
Okay, so I think we'll move now from Saudi Arabia and move to Kuwait. And it's my pleasure to introduce Dr. Akmal Muhammad. He's a cardiologist, Mubarak Al-Kabir Hospital. Am I correct? In Kuwait? Yes. Very good.
Oh, yeah, that one.
So, Dr. Akmal, you have 10 minutes.
10 minutes.
Yeah, this is the
Assalamu
rule.
alaikum. Thank you for kind invitation. Thank you, Dr. Ala. My case will go to basic. All the cases are advanced. My case will go to basics. He is an unfortunate guy. I have no disclosure. He's a 58 years old patient, previously hypertension, complained from frequent attack of dizziness. He's seen by ENT and seen by neurology, and sent him for echo. Sorry. Okay, this is a transthoracic echo. As you see, there is good ejection fraction with concentric LVH with thickened aortic valve. As you see here, you can appreciate mild aortic regurg and mild mitral regurg. Okay, this is a short axis, shows that there is thickened trileaflet aortic valve. Okay, in the apical four-chamber view shows there is mild plus mitral regurg. Okay, the mean pressure gradient was 45 millimeter mercury, and the aortic valve area was 0.8. Okay. My voices can cover all without this. Okay. As the aortic valve area was 0.8 centimeters squared, so we send this patient for aortic valve surgery. Coronary angio came first normally, but unfortunately during the surgery, something happened to the mitral valve iatrogenic by the surgeon, so he changed the mitral also during the surgery. So mitral and the aortic prosthetic valve were inserted with a small post-operative course. Okay, after 2 months, this patient came to our hospital again with an acute pulmonary edema, with one spike and fever, and there is systolic murmur at the apex. His lab finding, his hemoglobin is 91, and INR 3.1, total bilirubin is 120, and direct bilirubin is 9, with reticulocyte count was 5.1, with repeated blood culture came negative. We did transthoracic echo for him, shows that the aortic valve and the mitral valve all seated, but there is haziness in the atrial surface of the mitral prosthesis. We suspected this as a beginning as an infective endocarditis mass or versus artifact. Okay, this is a color M mode. We didn't appreciate any regurgitation for both of the valve. Okay, the apical 4. Also, we see the same haziness in the atrial surface of the mitral prosthetic valve, bioprosthetic. We suspected this is a vegetation versus artifact. Okay, this is the continuous wave Doppler over the mitral valve. As you see here, that the diastolic velocity is 2.4, and the mean pressure gradient across the mitral valve is 12 millimeter mercury, and the maximum is 24. Okay, this is the color for the aortic valve. It is nothing important in this, with no regurg. Okay, so we shifted this patient for transesophageal echo. We scanned the mitral. As you see here, there is no vegetation over the mitral valve, and nothing. The mitral valve is moving, seated well, with no any. When we go to the color, we didn't see any regurgent flow through the mitral prosthesis. This is a 4D surgical prospective view at 9 o'clock. This is the aortic mitral continuity. At 3 o'clock, this is the intra-atrial septum. At 9 o'clock, this is the left atrial appendage. We didn't see also any vegetation from this view. This is from ventricular aspect, also no vegetation. And when we make continuous wave Doppler, the same as a transthoracic echo. Okay, this is the aortic prosthesis also, no problem, with color with no problem. We scanned the mitral from different angle, 70 and 90, we didn't see, and 120, we didn't see any regurgitation through the valve. Okay, at angle 30, we appreciated here there is something like a sleep desuture or mass besides the mitral prosthesis. So till here, this patient came with heart failure, hemolytic anemia, and there is systolic murmur over the apex, and there is increased of transvalvular gradient over the mitral valve. We have a differential diagnosis for the transvalvular velocity increased, either prosthetic valve stenosis and obstruction, we couldn't see here. Prosthetic valve regurgitation, we didn't appreciate till now. High flow condition, increased heart rate, and the patient prosthesis mismatch. So we review our video again to scan why all the picture reveals that this patient has a regurgent volume, regurgent flow. So we repeat it again. If you look to the upper part of the left atrium, right side, there is turbulent flow indicating that there is regurg. But where it come from? So we scanned the mitral again with different angle until we reach 150. You will appreciate that there is space between the valve and the cardiac tissue. When we put the color here, there is clear, significant paravalvular leak. Okay, if we move toward it, this is significant paravalvular leak with an extreme Quanda effect, leading to the regurg like moving over the left atrial wall. When you put a continuous wave Doppler over this regurgent, you appreciate this. There is dense regurg, appreciating this significant paravalvular leak. Here we take another 4D view with surgical perspective view, but we make a mistake in the first 4D view. We didn't cover all the ring. Here we cover the ring, and you can see that there is between 6 o'clock to 7 o'clock, there is a gap. There is small defect with paravalvular leak. Okay, this is the first 4D view. It was wrong because we didn't cover all the ring. Okay, this is the regurgent flow. Okay, the area of the regurgent was 0.3 centimeters square. Paravalvular leak is a serious complication after surgical replacement, secondary to inappropriate sealing of the prosthetic ring to the native cardiac tissue, producing periprosthetic regurgitation. The diagnosis of the perivalvular leak, you should start clinically. This patient, if there is a small leak, it will be asymptomatic. 85% of the patient will come with heart failure. 14 to 47% from the patient will come with hemolytic anemia. About the hemolytic anemia will be common more with the aortic valve more than the mitral valve. Will common more with prosthetic valve more than the bioprosthetic valve, and the infective endocarditis. The echo will be the good standard for the diagnosis of the paravalvular leak, followed by the transesophageal echo also, and then CT and then cardiac MRI. Severe paravalvular leak are more common in the mitral more than the aortic processes, and rarely detected in pulmonary and tricuspid position. This is the surgical prospective view. As we said before, 12, this is aortic continuity, 3 interatrial septum, and 9 left atrial appendage. You will, in the mitral prosthesis, the most common location for paravalvular leak between 5 to 6, and aortic mitral curtain between 10 to 11 o'clock. Okay, why this position is between 5 to 6 is more common? Firstly, the posterior annulus provide limited surgical views that the surgeon cannot take a good suture in this area. The second point is that the proximity of the LCX will lead to more superficial suturing, and there is more calcification and fibrosis are more prevalent in the posterior annulus. This is the most important slide in our presentation today. This is the most basic. You should suspect paravalvular leak or regurgitation when you're assessing a prosthetic valve and there is diastolic increase in maximum velocity more than 1.9, in some box 2.2, mean gradient more than 5 millimeter mercury, and the VTI of the prosthesis to the VTI of the LVT more than 2.5, and the maximum velocity of the tricuspid regurg 3 meters per second. Traditionally, surgery is the gold standard treatment of the paravalvular leak, but now the percutaneous transcaster closure is an emerging. Okay, we send this patient for transcaster, but he is an unfortunate patient. It's failed. We tried with him with EVB2 and EVB3, but it's failed and send it for redo surgery. Okay, the take-home message, good history and the clinical examination before echo will guide you for diagnosis of the paravalvular leak, especially hemolytic anemia and auscultating the patient. When you take 4D make zoom, the area should cover all the ring. You can diagnose if there is paravalvular leak, and the indirect measurement for the mitral valvular is in the velocity more than 1.9, mean gradient more than 5, and the VTI of the prosthesis to the VTI of the LVOT more than 2.5, and the maximum velocity of the tricuspid regurg more than 3 meters per second. Thank you.
يديك العافية دكتور أكمل. It was very nice case. I think it's very important always to look for comprehensive assessment. The 3D always helpful in such cases, but if you have started with a good, clear 2D images. Yes, Abdurrahman.
Thank you. Very nice case. 2 points just to make. First of all, you have clue. Always when you have the maximum gradient out of proportion of mean gradient, suspect maybe you have a hidden paravalvular leak. This is one.
in your case, you have a very high maximum gradient, while the mean gradient is out of proportion.
Yes.
This is one. Number two, if you look to the guidelines for the assessment of the prosthetic valve, you have 4 steps. Number one, you have E mitral is high. You have the gradient is high. So the third step is pressure half time. Don't ignore that one. Pressure half time, especially our fellows. If the gradient is high and the E mitral is high, the pressure half time is normal. That means less than 130. This is a cutoff point. Less than 130. Also, again, you suspect functional stenosis, which is the paravalvular leak. And the fourth one, what you mentioned, the ratio between the VTI of the prosthetic valve over this one. So if it is more than 2.2, then this is good. Thank you.
Excellent presentation, Doctor. Thank you.
Any other questions?
Thank you, Dr. Ahmed. I think the missing slides should be mentioned, or I don't know why it is not presented. Why you don't apply color with the 3D? I think this will.
Yes. It is in our machine. It is not working well. So it is.
This can facilitate from the start. Can detect the. Okay.
Yes.
Very good. Yes.
The total bilirubin was 120. I don't know about reference of bilirubin with you. It is this 120 bilirubin. It was high or low. If it is high, I think it was mainly indirect. This sometimes give you a hint that there is hemolysis and LDH not mentioned in the lab, and also the inflammatory marker. This is about this case.
In the beginning, the total bilirubin is high, the reticulocyte count is high, and the direct bilirubin is also high. All in the beginning.
He put it in the first. So, thank you. We'll move now to the next.
Okay, thank you very much. Is Dr. Fathi Salim ready?
Yeah, ready.
Our next speaker is Dr. Fathi Salim.
Hello.
He is consultant
Assalamu alaikum.
cardiologist. Wa alaikum assalam wa rahmatullahi wa barakatuh. He is consultant cardiologist and head of cardiology in Medina Tayyiba in Alexandria. Okay, Dr. Fathi, most welcome. We worked together in 1990 in King Fahd Armed Forces Hospital. So this is just for the records. Go ahead, Dr. Fathi, please.
Assalamu alaikum. It is a pleasure to me to see Dr. Pasha, who is the father of echocardiography in the kingdom. First of all, I would like to thank you, the organizing committee of Almoosa Second International Echo Conference, for giving me this chance to present my cases. My case is about intramyocardial dissection as complication of pseudoaneurysm. A 65-year male patient presented to the emergency department complaining of progressive short of breathing for the last 3 months, was preceded by attack of chest pain. Patient not asked for medical advice at that time.
دكتور فتحي السلايد حقتك لا زالت
Yes.
الفيرست 1 just لو حضرتك تضغط على السكند سلايد وتخليها فول سلايد فيو، لانه لا زلنا شايفين الفيرست سكرين بس.
كده it moves or not?
لا لسه، لا زلت على سلايد نمبر 1. من عندك اول شيء افتحها وبعدين شير سلايد.
طيب I will stop sharing first.
You don't have a copy. Do you have a copy here? Okay. افتحها عندك في اللابتوب اول شيء.
Sorry for this.
كفول فيو بعدين شير سلايد.
Okay. Okay. Smooth now or not?
لا لسه والله فتحي.
Yes,
Stop
it is
sharing and share
inconvenience.
again. ممكن تزبط معك برضو. تحب فتحي نديك تايم نشتغل مع حد تاني لا تبدأ البرزنتيشن عندك؟
Okay, for time sake of time, you can start with another
طيب
one. I'm sorry, I will just adjust
فتحي
my
stop sharing
my
share بعدين open again your presentation حطها على full view بعدين كليك على share slide. Okay, we'll move to the next.
Please close the session now for Dr. Okay. You look ready, Dr. Fathi?
أيوة. Now is okay?
Yeah.
It's fine now? You can see the slide?
Yeah, but click for a slideshow.
Moving?
Just click for a slideshow first.
Yeah, and it's just a little bit slow. So, is it move now?
Yeah, it's not moving. We're still seeing the first slide only.
I will just apologize, and we can give me some time to adjust with the conference to help me for this. To adjust
Try,
my
Dr.
slide.
Fathi, to press F5.
Please direct him.
F5.
Doctor, can you please press F5 on the computer, on the lock keyboard? F5.
Yes, I press F5.
Press on the PowerPoint, select the slide, and press on F5 then.
Okay, I will go out.
سوي select تحت جنب ما هذا you stop the share screen.
طيب يا فتحي تيك يور تايم. كل مرة بتعشمنا. دحين هذا السكند سلايد. طيب روح اللي بعدها اضغط اللي بعدها.
خلاص.
ايوه هي هذه يا سلام عليك.
It's not me actually.
والله يا فتحي حنقص منك 5 درجات بس عشان كده.
والله thank you very much for your patience, all of you.
يلا نتوكل.
Anyhow,
بسم الله.
this is a
خلاص
case
يلا
of
توكل.
intramyocardial dissection as a complication of pseudoaneurysm. This 65 years old gentleman presented to the emergency department complaining of progressive short of breathing for the last 3 months. Was preceded by attack of chest pain. Patient not asked for medical advice at that time. Transthoracic echo done, and it showed pseudoaneurysm of the basal part of the infero-posterior wall, located at the origin of the posterior papillary muscle. This is the pseudoaneurysm, as you can see, appreciated now. It is the wall is thin and formed by the epicardial and pericardium. So pseudoaneurysm on the T2D echo, the neck is rather smaller as compared with its depth. The wall of the surrounding normal myocardium does not become the wall of the aneurysm, and the initial portion of the pseudoaneurysm wall turns back and can be seen behind the wall that ruptured during its formation. As compared with the true aneurysm, the neck of the true aneurysm is large in relation to its depth, and the wall of the surrounding normal myocardium turns thinner as it becomes the wall of the aneurysm. the aneurysm is not seen behind the adjacent wall. As we can see here, there is the wall of the aneurysm is behind the edge of the myocardium. So patient admitted and coronary angiography done and showed total occluded right coronary artery. Unfortunately, the patient admitted also and advised for going for surgery, but unfortunately the patient refused cardiac surgery and insisted for discharge due to family commitment. After 1 month, the patient presented in emergency department in cardiogenic shock. Transthoracic echo repeated, and it showed intramyocardial dissection involved the inferolateral wall and interventricular septum. So as you can see, this is the inferior wall, and there is a laceration and dissection of the wall, and interventricular septum shows dissection here, and here also there is a line of dissection in the interventricular septum. The left ventricle is compressed by the large intramyocardial dissection and hematoma. So after discussion with the cardiac surgeon, patient shifted to operation room for emergency surgery aimed to control this fatal complication. Intraoperative TE showed very aggressive and very progressive intramyocardial dissection with a large hematoma compressing on the left ventricle, involving the inferolateral wall and interventricular septum. And you can appreciate the line of dissection with the flow from the left ventricle to the intramyocardium, to and fro flow color at the site of the insertion of the posterior papillary muscle. The mechanism of intramyocardial dissection in the setting of inferior wall pseudoaneurysm has three components. First, the contraction of the posterior papillary muscle towards the base of the left ventricle. The second is the increased tensile strength on the free wall of the pseudoaneurysm adjacent to the neck of the aneurysm. Dissection among the spiral myocardial fibers, creating a new cavitation, and may cause rupture of the intramyocardial vessel, causes more hematoma and increase the size of the dissection. If we go back to the first echo done 1 month before the patient presentation, you can see this is the site of the papillary muscle here, and this is the free wall of the pseudoaneurysm, and you can appreciate the different movement of the free wall during systole. So these two opposing mechanisms, the papillary muscle pulling the ventricle inside, and the free wall of the left ventricle is pushing the outside. These two opposing forces can initiate the dissection. The third component is the structure of the left ventricle, which is composed of 3 layers of spiral muscles, and there is an intraventricular small vessel. With the cleavage of these layers during this dissection, these vessels rupture and cause more hematoma. So this mechanism, in our case, the dissection initiated at the site of the insertion of the posterior papillary muscle with the neck of the pseudoaneurysm, which could be explained by the two antagonizing forces during systolic phase. The inward force of the contracting papillary muscle against the outward pushing of the free wall of the pseudoaneurysm by the high intraventricular pressure during systole. These two opposing forces causes dissection at the fibril spiral muscle. With more dissection causes disruption of the intramyocardial small vessel, causes more hematoma and more dissection. So the conclusion, left ventricular intramyocardial dissection considered as a rare complication of myocardial infarction, usually of limited size due to rupture of the small intramyocardial vessels. And most of the reported cases only involve a small area of intramyocardial infarction in setting of acute anterior MI in the area of interventricular septum or free wall of the left ventricle. Here, transthoracic echo is a reasonable first examination to diagnose intramyocardial dissection because it is non-invasive in expensive and very reliable and portable, also can be done as a portable machine. Color Doppler can indicate a low velocity flow profile in the abnormal route, as in our case. So dissection of myocardium as a complication of myocardial infarction at basal segment between the site of insertion of the posterior papillary muscle and the base of the heart in setting of pseudoaneurysm is a very rare fatal complication and was not be reported before. And this is the first case to be reported and published in Journal of Hypertension and Cardiac Care. I would like to thank the chairman for patient and giving me this chance.
Okay, thank you very much indeed, Fathi. This is a very nice case. Any questions for the case? What happened to the patient, the outcome? It was published, so he must have survived.
Unfortunately, the patient is not survived. But I published this case because...
Oh, dear me. Anyway,
because this site of pseudoaneurysm is very uncommon and very rare. So we should be careful about this site because the insertion of the posterior papillary muscle can cause more traction on the wall and should be managed very early before any complication like dissection happens.
Okay, thank you very much. Well, that shows that you should not be disappointed if you patient still get the paper published, because there are important messages from interesting cases, regardless of the survival, whether the patient has survived or not. I think there are still important messages you can derive from such cases.
يديك العافية فتحي، ونحيي السيرجن اللي أخذ المريض هذا للحالة. بليف مي 9 من 10 ما حياخذوا الحالة هذه للأو آر. فتحي لو تكرمت ستوب شيرنج، اضغط على الازرق هذا اللي مكتوب عليه ستوب شيرنج في الشاشه تحت عندك.
اوكي
ايوه اضغط عليها ونشوفك دائما على خير ان شاء الله. كل سنه وانت طيب.
الله يخليك. شكرا شكرا.
Next presentation will be by Dr. Mahmoud Shahata. Dr. Mahmoud Shahata lecturer in Port Said Medical School, Faculty of Medicine. Dr. Mahmoud.
Well, unintentionally, I shared the same thoughts with Dr. Akmal that we have to go basic after all these complex and magnificent cases. But I promise you that I will go more basic. Okay, my presentation is entitled A Very Regular Daily Case. At least in my homeland, it is very common to meet these cases. We present a case of 42 years old mademoiselle. She has a special look, abnormal look, with subnormal IQ. And she has a short stature with her body surface area is 1.37. She has a long history of knowing rheumatic heart disease. And she was referred for assessment of her mitral stenosis severity as they have plenty of echoes, mild, moderate, severe mitral stenosis in a very short duration. So her transthoracic echocardiography, this is a parasternal long axis view, as you know, and here we can appreciate the thickening of the post leaflet and the limitation of its excursion. The four-chamber view here, and with aid of the colors, we can appreciate how much aliasing of the color coming out of this mitral valve, so we can expect that there is some stenosis significant. And here we go to basics. By the guidelines, we have lots of methods, at least 6 methods, to determine the severity of this mitral stenosis. And the first is pressure half time. So the transmitral flow, Doppler flow spectrum, using pressure half time reveals that the mean gradient first, mean diastolic gradient is 16.5, and this denotes a severe stenosis. Here, in the three-chamber view, we can appreciate the subvalvular apparatus, thickened with shortened chordae and matted papillary muscles. And reverting back to the guidelines, the echocardiographic assessment of valve stenosis, the gradient assessed by Doppler flow is not the best marker because it is not dependent only on the severity and the mitral valve area. It usually depends on the flow, the cardiac output, the heart rate, and if there is associated significant mitral regurgitation. So go directly to the second method, which is direct planimetry. Again, we give the long axis view and we rotate our probes to get the short axis view, this mousefish appearance of the mitral valve, and direct planimetry and tracing get us 1.1. This is a little bit larger than the, this for moderate mitral stenosis, not coincident with the severity of mean gradient, which is 16.5. Again, the guidelines, they are telling us that this 2D planimetry is theoretically the best option because you are directly tracing the anatomical orifice of the mitral valve, and so you get the anatomical as compared with the true anatomy of the mitral valve. So we have 1.1 centimeter square by planimetry. But we have limitation of 2D planimetry, so we have to continue. These limitations are namely poor acoustic window. Maybe you have distorted anatomy, you can guarantee the tracing of your valve, and it depends on your technical experience. The third method is pressure half time. Pressure half time, you get the Doppler flow across the mitral valve, and by pressure half time, here we have a 1.3. Again, it is more moderate mitral stenosis, so the valve area is getting larger. The limitation of pressure half time, if you have no straight slope, you cannot trace the pressure half time. If you have two slopes, like patient in sinus rhythm, you cannot give a good pressure half time. And again, it is affected by the chamber compliance, namely left atrium and left ventricular compliance. Go for the fourth method, which is continuity equation. And this is the equation for continuity. We can get the left ventricular outflow tract diameter and the pulsed Doppler across the LVOT and the VTI across the mitral valve and put it in the continuity equation. Now you will have a more severe mitral stenosis again. It is 0.9 centimeter square. What is the limitation? What are the limitations of this method? We cannot use it in atrial fibrillation because you will have different VTIs across the mitral valve and across the LVOT. And you cannot use it if there is a significant associated mitral regurgitation or aortic regurgitation as well. So move for another method, which is BISA method, proximal isovelocity surface area method. And the proximal isovelocity surface area method is a very complex equation, actually. It depends on multiple variables, the BISA radius, the Elsing velocity through the valve, and what we call the opening angle, alpha. So from our case, the BISA radius is 1.25 centimeters, the Elsing velocity was 34, and the peak velocity across the mitral valve was 215 centimeters per second. And regarding the opening angle, which is the alpha angle, this is the most tedious part of this BISA radius, because you have to print out this slide or this echo view and use your protractor to manually trace or to get the alpha angle. And I think I will not do it by myself. So I searched in the literature, and I found this very good paper from India. They also have a lot of mitral stenosis like us. And they concluded that it will not make big difference. You can use a cutoff or a constant of 100 degrees this for the alpha angle in all cases, and this will be more reliable. So when we put this in our equation, we have a 0.9 centimeter square. So we have a continuity equation of severe mitral stenosis. We have BISA of severe mitral stenosis. We have mean diastolic gradient of severe mitral stenosis, and other methods in a moderate degree. The advantage of BISA that it can be used if there is an associated significant mitral regurgitation, unlike the continuity equation. But it's a limitation. It is very technically demanding. And we resort to the last method, which is 3D echocardiography and 3D valve planimetry. And this is the gold standard, actually, because it is the most accurate method for mitral valve area evaluation, and it is a reference method. So when we put our axis and using MPR, we can appreciate here how much oblique the valve area is. You cannot trace it in 2D wise because the opening is very oblique, so you have to make an MPR to get the true opening of the mitral valve. And now we have, again, a severe mitral stenosis, 0.8 centimeters squared. So final words, that we have a severe mitral stenosis by a majority of direct methods, and another methods supporting a little bit this severity and goes more to the moderate state. So I have a question here. Does anyone in this very direct case have any impression about the etiology of this mitral stenosis other than rheumatic heart disease? Parachute, yeah, okay. Any other thoughts? Okay. Sorry? Okay. Okay, sorry. So, we resorted back to a paper. Yes, you are right. Severe mitral stenosis secondary to Hunter syndrome. And this Hunter syndrome is very rare, genetically determined disease of mucopolysaccharidosis. The clue here is that you have a facies of short stature, subnormal IQ, abnormal look. And if you see in these papers, there are pictures, actually, it's very similar to this patient. You have thickened mitral valve, looks like very rheumatic mitral stenosis, actually. But another clue, other than the facies of the patient, is the left atrium in the M mode. Because if you trace the left atrium in the M mode, you will find that the anteroposterior diameter is only 33, which is not that coincident with severe mitral stenosis. So it denotes that there is some infiltration of the left atrial wall, which hinder its more expansion, and so you should think about infiltrations. So our take-home message is that you have to pay more time and effort to use all available tools, and you have to correlate the different markers and go with the majority. So you have to pay attention to not only the tools, the sensitivity of the tool and its specificity and its limitations. Respect the indirect signs of severity. If you have a high pulmonary systolic pressure, if you have a large left atrium, if you have such a valve anatomy with restriction of movement, you can consider and go with the majority of the markers, which is severe stenosis. And whenever available, use the advanced techniques like 3D echo to ease your life. And thank you.
Thank you, Dr. Mahmoud, for this nice presentation. And I will start with the first question. I think according to the guidelines, also pressure half time indicating that mitral valve was severe, was not moderate. 1.3 is severe, it's not moderate.
I'm expecting this question, by the way, because we have still a gap between the guidelines for echo and the guidelines for intervention. We still, in echo, we consider that there is a moderate stenosis between 1 and 1.5. And this is, I think, a gray zone, because if you have a asymptomatic patient with a valve area of 1.4, and it is not a ballonable mitral valve, so I am just asking, will you go for direct surgery in a young female patient with mechanical prosthesis and in a 1.4 asymptomatic with low pulmonary systolic pressure? If it is ballonable, okay, you have to go, I think. But I think we have still a gap and a gray zone between the area of 1 to 1.5 in asymptomatic patient. I think so.
The decision for management is different, but regarding the definition of severity, it's severe mitral stenosis.
Yes, I agree with you.
And number two, the BISA and continuity equation is liable for multiple errors.
Yes.
So nobody recommended to use it for calculation of mitral stenosis.
Still noted
theoretically, but not in the practical.
Yes.
Can I have a question? I have a comment. يعني حضرتك طحت مع أطفال دحين. Hunter syndrome is an X-linked mucopolysaccharidosis. So this should be a male, not a girl. So do we know that she is really a Hunter or just mucopolo?
Okay. Actually, the histopathology came that it is some mucopolysaccharide infiltration.
Yeah, so you have to test the urine and the blood for mucopoly. So Hunter, min Hunter, it's X-linked. So we remember it, that's Hunter, okay? So that's one of the educational points. Now, these patients of mucopoly, they have the position of this material, and you usually have regurg plus stenosis. Does this one has regurg?
No.
So I was wondering.
Completely stenotic.
And they have hepatomegaly, because this is one of the, did she have hepatomegaly?
I cannot tell you exactly because
They have coarse features, thick eyebrows, short stature,
yes.
hepatomegaly, and so on.
Yes.
My last question, I want to learn from the adult cardiologist, why is it, I know it's not rheumatic, but I want to know why it's not rheumatic valve.
It is for me, from the first impression, it is most common, which is mitral stenosis. It's rheumatic by default. But the other signs, indirect signs, like small left atrium, and the abnormal morphology of the valve, which is more homogeneous thickening of the valve leaflet from the base to the tip. Usually mitral valve stenosis, rheumatic origin, we have a more thickening and the tip more than the body of the leaflet. So I think it was very homogeneous. The anterior and posterior was homogeneous, the second perfectly like each other.
From the beginning.
Yes, yes. There's some hockey stick appearance of the anterior leaflet, but it's not dooming like perfect rheumatic heart disease.
Just a question. Hello?
Okay, I think we move.
We know the
Just
sorry,
last question,
Last
please.
question. The limitation of all the modality you mentioned, but the simple one is the once you have the 3D probe, you can activate, explain on the tip of the mitral valve, and you can get the area. The area you get is the first one. It is not in the tip. Because of that, it is overestimated.
And this is also the perfect problem in this case because at every time we have no 3D probe until the last time we put it on 3D and planimetry it. Yes.
Okay, well, thank you very much indeed. I think we move on now to Dr. Muhammad Salah. Is the last presenter for this session. He is the consultant cardiologist and head of non-invasive echo lab in Prince Mohammed bin Nasser Cardiac Center in Jizan. Most welcome. Well, I think just to show how interested is echo workshop and interesting cases. Just why they are preparing, I remember when we initiated the echo workshop in 1997 in the Saudi Heart Association, I must actually give gratitude to Dr. May Al-Shahid and Dr. Ahmed Umran. The three of us, we started in 1997. And I think many of the senior cardiologists here remember these old days with the videotapes. No internet and no computers at that time. Please go ahead. Thank you.
My great thanks for the organizing committee and for the panelists. I will share with you my presentation. This is a 50-year-old male school student presented to our hospital complaining of shortness of breath, NIHA class 2 with decreased exercise tolerance for several weeks. Systemic review was unremarkable, no past history of medical illness, no family history of similar disease, musculoskeletal system, and neurology was unremarkable. Clinical examination, he is average built with no deformities, heart rate and hemodynamics all within accepted range. Examination, chest fine by basal crackles, cardiovascular displays apex normal, first, second heart sound, no audible murmur. Abdomen, nothing there, just lower limb is mild level. The initial blood sample, including biomarkers, CBC, chemistry, all within normal, and ECG shows sinus rhythm with inverted T wave in V3, V4. This is X-ray showing clearly pulmonary congestion and increased cardiac silhouette. This is a transthoracic echo. Showing apparently a huge left atrium. Sorry, why not working this? Why not working the movie? Okay, the LV is dilated, the LA is also dilated. Here, the apical four-chamber view showing a very prominent trabeculation here involving the anterolateral, the inferoseptal, and even the spontaneous echo contrast was obviously seen here, and even the apical four-chamber view. So there is prominent trabeculation in the inferoposterior and the anterolateral, and the RV is also have this feature. And the spontaneous echo contrast is clear in the LV cavity. Regarding the valve, we see here in the valve there is a Doppler across the mitral valve. It shows like dense triangular on the right side, and there is blunted pulmonic systolic flow, indicates that the MR is significant. You see how big is the LA and how the ejection fraction is reduced in maybe in severe range. And the MR is significantly severe, moderate to severe. And the tissue Doppler also is affected significantly. Again, the same picture. So from this view, we can apparently see how the LV cavity is with prominent sinusoid or trabeculation. This is the inflow and outflow, showing pulmonary valve is mild PR and the TR is maybe moderate. Regarding the tricuspid valve, it shows like moderate to severe tricuspid regurg, and the pulmonary artery pressure is around maybe 65 estimated pulmonary pressure. So this is the MR. If you look to the valve is thickened. And this is the hepatic vein, show reversal, systolic flow indicates severity of the tricuspid valve. And the RV here, clear the TAPC within normal, and the velocity by the tissue Doppler within normal. That means the RV is normal functionally. So we suspect this, it looks like non-compaction. We asked to do a cardiac MRI, and cardiac MRI confirmed this is a case of non-compaction. So this patient simply presented with heart failure with feature of non-compaction with moderate to severe MR, TR, and pulmonary hypertension. Patient started standard care management of heart failure, including bisoprolol, lisinopril, empagliflozin, aldactone, furosemide, and enoxaparin. Patient start improved. This is the anatomic feature of LV non-compaction. You see how the trabeculation is prominent. Now the LV non-compaction was labeled as congenital anomaly of LV myocardium, and they label that because of the arrest of maturation of ventricular myocardium, as leading to persistent of weaker early embryonic largely trabeculated myocardium. The prominent trabeculation is a good sign. We can trigger the investigation for that, and there is deep intratrabecular recesses. Continuity between the LV cavity and recess primary in myocardium. This disease was labeled as primary cardiomyopathy. This in 2006 in the WHO as primary cardiomyopathy. Genetic myocardiopathy by American Heart in 2006. European, the question is LV non-compaction is a cardiomyopathy or this not. If you look to the diagram here, trabeculation process start early in the prenatal time at 6 weeks here, abundant fine trabeculation, and at 8 weeks it become more solidified, and at early fetal period should almost be completed. Regarding the prevalence of the disease, it affects children, adult, elderly, but most probably diagnosed early in the children. It was about 0.5 or 0.14. Men are more affected than female. There are some cases are sporadic or familial. Systemic review reviews that 30% or in family members have a screen based on index cases. There are multiple genetic proposals of phenotypic development of non-compaction, but none of them have the consistency to identify that the LV non-compaction is attributed to a single gene. Regarding the echo, traditionally the echo 2D echo is a standard initial assessment for LV non-compaction. It is still most common initial one, and we have four proposed diagnostic criteria: the California criteria, Zurich criteria, Vienna criteria, and Patrick criteria. But there is no well validated. If you look to the first 1, 2, 3 criteria, in one patient, they cannot give the same agreement. In other words, there is no concordance between the three criteria in a confirmed patient. This is the first diagnostic criteria. This is chain criteria. It was published in 1991, and it just see the ratio between X and Y. X is the trough of trabeculation, and Y is a peak of trabeculation, and this by end diastolic time. 1 minute, Muhammad. Okay. Another criteria, Zurich criteria, the idea both between the non-compaction and compaction ratio. Regarding the criteria, if you look here, we have MRI criteria on the right and on the left. On the right, cardiac MRI, 2.3 increase of non-compaction to compaction, and chain is 2.3. Cardiac MRI can give more information, especially about the late gadolinium enhancement. The patient presents usually with heart failure, dyspnea, chest pain, arrhythmias. Our patient presented with heart failure. We start him all the anti-failure treatment, and we send him for further management, and he have been transplanted. So take home message: LV non-compaction is phenotype rather than a single disease. No lab test, genetic test confirming LV non-compaction. Echo and MRI, there is no gold standard. Regarding diagnostic criteria, multiple modality may be needed to reach diagnosis. And thank you.
Thank you very much indeed. Nice case. And any questions? Yes, Doctor. I was expecting Dr. Rima Badr to talk about non-compaction because he showed the slides, fetal slides.
Yeah, I think it's a very nice case. I have diagnosed cases with fetal non-compaction in fetal life, and the prognosis is poor. Once you diagnose them antenatally, most of the time they don't complete the gestation to 40 weeks, or they die in the neonatal period. And this was published, actually. Another name for non-compaction is spongy myocardium. This is another name that in pediatrics. Number 3, there is also RV non-compaction. It's not just LV. We know about LV, but RV also can be non-compacted. And thank you.
Sure.
Thank you very much.
This
Excellent.
patient also, if you look to the one view, the RV is non-compacted. Yeah.
Okay, next question, please, Dr. Ahmed.
Yeah.
It's more of the systolic reversal.
It is systolic reversal. Yeah.
Okay, I think if there are no more questions, we would like to give the floor to Dr. Can Sarah conclude? Thank you very much.
I'd like to thank really all the speakers. It was a very interesting cases. We learned from it. It was challenging. I think, as I told you, the whole idea of really to give a stimulation for the attendee and, of course, a stimulation to the speakers. So we're going to take the average of the 3 marks. None of us know who will be the winner except Ala, and he will announce it tomorrow. But I think there will be a good, nice prizes. But the more prizes, not in this, will be in something different. That is, you need to stay with us because the next session will have a true nice prizes, cars, watch Rolex, iPhones. And 6 prizes. So imagine. So our next session will be the JEOPARDY. The JEOPARDY will be led actually by 2 eminent people in the field of the echocardiography. Dr. Osama Al-Muqbil, he's a consultant cardiology, echocardiography and heart failure from King Khalid University. And Mrs. Zain Abdel Hamid, she's an echo technician at King Khalid University Hospital. I think the beauty of this session, that is it has a hybrid mode. What does that mean? All of you, if you like to participate, you need to download the Kahoot application in your mobile. So the question will come, the one who answers first, he will get highest mark. Now the problem with this Kahoot, if you did a mistake, then it will be by minus. So that's it. Am I going to give you a Lexus car just to click on Kahoot? It won't work, صح, Dr. Faiz? So just download the Kahoot application in your mobile in order, if you like, to win the watch, the Rolex, the iPhone 15 or 16. Okay, Zena, go ahead. The floor is yours.
Good afternoon, everyone. Thank you so much for having us here. Thank you for Almoosa Health Group for having us. It's a true honor to be here. I know it's been a long day filled with many interesting cases. It's been very interesting and very informative. Thank you for all the presenters. Many of the questions, I shall say, have already been presented similar ideas. So it's going to be interesting. I'm going to explain the Echo Jeopardy this year will be through a Kahoot competition due to the hybrid nature of the conference. So the virtual participants can also participate in the game. We will be using, as I said, the Kahoot app, and this is the logo of the app. I'm going to need you to follow these instructions to join the Echo Kahoot. Scan the QR code to download the app from your mobile. And we advise you to open the session from your PC or laptop for those that are watching us over YouTube in order to use your mobile device and participate in the game. This is the to the next slide. Now let's begin the tutorial. Once you open the app, you have to click join, and the players that will enter the game pin. Don't enter anything yet because the game pin, we don't have it yet. I'm just showing you what you would see. So those that are watching us online, you will see the PC screen on the left. This is what it would look like for you from YouTube. And the mobile phone is what you would see on the right of the screen. So you would just enter the game pin that is provided by Dr. Usama or scan the QR code. You will have two options here. Either enter the pin or scan QR code. After that, you would have to enter your full name in the nickname box. After you enter your name, you click OK, go. Your name will appear at the bottom. You will see people joining the game. We will give you a couple of seconds to join the game and gather as many people as possible. After that, the question and answer choices will be displayed in the hall. Mobile phone will have these 4 colors. It's like a keyboard. So for you to pick the answers, you would have to choose the color. However, if it's a true or false question, you will only have 2 colors and you would have to choose either true or false. Keep in mind that there are some questions that will have multiple right answers. So it would give you, on the screen it will appear multiple. It means that, for example, all true except following, this would be one answer. Or select all true answers. So you would have more than one answer, but after checking the boxes that you want to answer, you have to click submit. If you don't click submit, it will not go through. Once all players have answered the questions, the correct answer and a bar graph with the overall snapshot of the players' responses will be displayed on the screen. Once the Kahoot is over, the winner's information will be displayed in the podium, and we will have first, second, and third place, as I mentioned. This is what it would look like. You would see what was the correct answer, and we would see how many people got it wrong, right, and which one was the correct one. Finally, once the Kahoot is over, this is the podium. We will have 3 winners for each game, first, second, and third. And if you are one of the winners, please take a screenshot or save the screen, the image, once you finish the game. A very important tip in order to win, you have to answer not only correctly, but quickly. Be sure to join us for a fun and a nice challenging game. As I said, we will have prizes for 6 people, 3 for each challenge. Make sure to join even in the second round. If you're not lucky in the first time, maybe you'll win in the second time around. I'll leave the floor to Dr. Usama now.
Great. Nice.
We will have a test in the beginning. He will show you.
طيب السلام عليكم ورحمة الله وبركاته. Good evening everyone. Thanks again to the organizing committee, Dr. Ala, for the kind invitation and for the amazing conference. Very interesting صراحة cases, very challenging, amazing صراحة. And زي ما قالت زينة, it's most of the questions will be actually from the cases you guys just saw. And some of them, inshallah, you will learn about them tomorrow, inshallah. So we're going to start with the test. Zina did a great job by explaining how the game works. I hope everyone got it. If you did not, then the test one will show you how to do it, hopefully. Even if you're a slow learner, which most of us is, you will be able to catch up. We're not interventionalists, I hope not. Okay, good. طيب, let's see. Ready? Okay, so let's start the test. The test has no points, so don't worry if you don't score high. لأنه Dr. Ala did not give us prizes for the test one. طيب, good. So let's see. Ready? Good. So this is the test. Make sure it's a test. So it's a test Kahoot. Yeah. Start. نبدأ. This is the pin you will get. Either you scan the code. أروح للبيج سكرين أحسن. So this is the pin you're gonna enter. or you scan this and على طول you will go to the hole, to the game. فايذر you scan the code or you put the pin. If you can't see the pin, then scan. Otherwise you enter the pin. We're gonna go slow. لما الناس تمل. Now I'm seeing people. Okay, so I like, wow. Slow down, guys. Good. So I see, mashallah, a lot of people entered. Wow. Oh, we. Good. Good, nice. So that's good number. Yeah, probably better to enter your full name, like مثلا FA. If you win, then we'll double A. If you win, we don't know how we give you the prize. We'll send it to AA, and we don't know who's AA. So better to put your full name if possible. Otherwise, you can screen capture it and we'll get it to you. So we're having some technical issues, but I'm seeing my screen. We don't see the full screen here now, ولا? No, good now. Okay, good. ها؟ والله ما لمستها. ولا قربتها. طيب. Good. Good. So, mashallah, عندنا enough number. So, 45 so far. So, good. So, I think we should start. ولا Yeah, we do. في YouTube, they can join. You don't know which one. يعني جزء من هذولا they are here. جزء منهم they are YouTubers.
We don't know who's virtually participating or from here. But anyone can participate as long as they scan the QR code or enter the game pin.
Yeah, wow, mashallah. So good number of people. So if everyone is ready, we're going to start. Then again, this is test, so just to learn how to do it. So no points. We're going to start. نبدأ. Zain is going to do it. So start. First question is, okay, so this is, we're going to see the screen, and you can answer through your mobile phone. So this is the test session. 3, 2, 1, then you will get the question. No questions. Good. Good. So this is the introduction. So we're going to go to the next quiz. So this is the first question. Which club is not playing at Roshan Saudi League this year? So Al-Adala, Al-Hilal, Al-Nasr, Al-Ahli. And I had to look it up last night. This is my gift to all people from Al-Ahsa. It's been a pleasure to be here, to be honest with you. But I just realized, خلوا السؤال يخلص وبعدين people will vote. Good. So 19 people get it right. I believe these are the people from Al-Ahsa. So unfortunately, people from Al-Ahsa knows probably, Al-Adala is not part of the major league this year. They were last year. So this is the scoreboard. So double A, which we don't know who he is or she is on the top, mashallah, because he or she scored correctly and fast. So the take-home message is, and I think next we're going to go over the... No. So how can we go back to go over the... go back? Back? Go back? So go back to review the question itself. It's okay. So, okay, we're going to move on. Okay, fine. So بعض الأسئلة حتكون true and false. So you're gonna, Kahoot is simple to use. Vote true or false. You answer correctly and fast. Good. So 19 said true, 3 said false. I don't know why they said, yeah. It's simple to use. I don't think it's actually, we give it to the children in the schools to do it. So if you cannot cope with this, then probably you have to go back to elementary school. Good. Okay, good. So it's easy to use, too simple to use. Good. So next, then if we have multiple questions, this is an example of multiple answers. Next. نشوف الحين إلى الآن triple A is still the winner ولا لا? Triple A? Who's triple A that, by the way? Double A قصدي, double A. شكله. طيب. Good. Physicians. Okay, next. شو؟ ها؟ yeah. ما في له سؤالين true false صراحة easy. color I don't know والله بس يبدو لي انها fixed. في سؤالين بس فقط true false. بس yeah I think انه fixed color. yeah. اوكي ورانا ايش في مشكلة؟ ما في مشكلة. So now, okay, mashallah, Muhammad al-Amri now is on the top, Akram still the second, Faye is on the third, and it shows you how, you know, the people progressed. So Muhammad did amazing job in the second question, that's why they jumped to the first place. Good, next. So again, this is test, no prizes. So يعني محمد don't be happy. شوف الفيس حقك كذا smiley. طيب, you won't be smiley anymore. Okay, good. Next what? Yeah, next. So the third question is multi-select. معناتها multiple answers are right. To perform an echo scan, you can use right hand, left hand. I don't scan, I call my tech. Well, I use artificial intelligence, and you're going to hear about it inshallah tomorrow. So vote or answer the correct answer. أتمنى nobody used the yellow one. How many ticks هنا? How many echo ticks are here? 1, 2, 3, 4. Okay, oh, mashallah, good number. Okay, so let's see the answer. Oh, okay, so 39 use the right hand, 22 left hand, only 3 got the tech. Good. معناته البقية they do their own scan? Come on, give me a break. Right, نشوف الانكول. We'll see what you do for on call. You'll call the tech. And 11 use artificial intelligence to scan a patient. Wow. Well, more to learn, mashallah, Dr. Ala, tomorrow. Good. So now you get how to play the game, صح? Okay. Now, Paul, are you ready for the challenge? You can vote. Yes, I'm ready to win. No, I need more clarification. No, I need more time. No, I'm in the wrong place. I'm interventionalist and just joined you guys by mistake. Answer.
Well, as you can see, the timer is on the left.
Yeah, good.
There's like a countdown.
Yeah. And everyone answer at the same time, like كلكم خلصتوا on time, the timer will finish actually ahead of time. So mashallah, all of you are ready to play and win, but keep in mind only 6 people will win, and only 1 in the wrong place, so please leave. And I know who he is. طيب. Good. في مباراة هلال راح شوفها. طيب, next. Good, so we're gonna start now. Okay, ready? Everyone ready? Good. Okay, so we're gonna go. Oh, يا صح, نشوف مين اللي فاز بالتست. And unfortunately, so number 1 is, wow, the smiley guy. محمد المري. محمد المري, you get nothing. Second, Akram, you get nothing. Sorry, second is Faye, you get nothing. Then Akram, you get nothing. But this is probably يعني كذا يعني just to give you a push for the second inshallah one. Good, so ready for the challenge. Let's get started with first Kahoot. The real one now. The one we will get prizes for the top 3. Good, any questions قبل ما نبدأ? Yes. مرة ثانية, new pin. So go back, join. I'll go back to that. Oh, you scan the code when we get the code. So go back, new game now, new game. People who did not participate can participate now to win. And Dr. Ala just told me 6 prizes and valuable. كان سمعت الدكتور كنسارة قال cars, Rolex. Yeah, we'll get a new pen. يلا بس خليهم يجهزون second one. الحين جالسين هم they're cooking a second one. Cooked, well done. Cooked, yeah. يلا, well done. بعضهم يبغون medium well. Good. أذن المغرب. مين يقول أذن المغرب؟ والله بقى 10 دقائق. والله عندكم بالحسا يذن بدري, عندنا بالرياض لسه 12 دقيقة. طيب نخلص الجيم قبل أذان المغرب إن شاء الله. يلا بس خلينا نبدأ second. طيب good, so ready, huh? طيب, this is the second one. You can see it now. Good. So no code yet. We'll start. And don't worry, ما في points إلى الآن لما نبدأ الجيم. So get ready. You will get a pin now. And this is your pin, 9193095. Or scan the code and you get the game. So 9193095. Very nice pin. طيب, only 1 joined, mashallah. 2. Good. So familiar names, mashallah. So again, yeah, good. في واحد دخل رقم اسمه حط رقم I don't know why. Fine. Good. Lots of smiley faces, baby. الجميل baby. Good. Big baby. Good, so we have 40 so far. I think we got 45 in the test one, so we'll wait a few seconds.
Just a reminder for those that are playing the game virtually, you can also join the game from the game pin.
So we get we get almost 50 now. طبعا if you join late, you will find the code below in the screen. So even if you join late, you can join the game. Ready? والله ما لمس شيء.
We have
50. We'll get started. Good. Everyone is ready? يلا بسم الله. We'll get started. First question. Start. بسم الله على بركة الله. نبدأ هذه اللعبة. And the winner. No, not yet. Good. So the first question is. أنا نسيته والله. Parasternal, apical, subcostal, suprasternal. Vote. إذا في واحد جابها خطأ, I will leave and will not finish the game. Except the one اللي watching الهلال's game now. كم النتيجة؟ طيب. So 40 got it right, apical. 4 got parasternal. طبعا أول صح إنه أول حاجة نسويها parasternal, but this is not right. Good. So نشوف طبعا show the media بس to go over it. This is apical يا جماعة, clear ها؟ حتى non-medical can know it. طيب good. So we'll move to the answer or people اللي got it right. طيب أكرم, I don't know what he's doing. He's from the test one. He's still doing amazing. He's number 1. بعدين أبرار العلي وبعدين خولة. Dr. Midu Faye are in the second. The second question, a 52-year-old female with rheumatic mitral stenosis, pressure half time 220. What's the calculated valve area? 2, 1, 2.2. No, I need a calculator. Answer. You need a calculator. Oh my goodness. ما جابوا لنا الموسى calculators. يعني just explained 2 seconds ago or 2 minutes ago how to calculate mitral valve area by pressure half time. So 5 seconds to go. 4, 3, 2, 1. Okay, so the correct answers. 33 got it right. Not bad. ولا زينة. Yeah, so 33 got it right, 6 got it wrong. حط بس الصورة. It's easy جماعة. إيش pressure half time? الvalve area pressure half time divided by 220. So 220 divided by 220 is 1. Easy, ها ما يحتاج لها calculator. If you really need a calculator, then no comment. Good. Next نشوف ما شاء الله. Okay, أكرم still ما شاء الله on the top. والله أكرم, who's أكرم? Can I know أكرم بس عشان وين؟ أكرم نياز. I didn't realize you. Okay, amazing والله. Oh wow. You are from the first Kahoot, ما شاء الله, winner. طيب next. All of the following are components of the Wilkin score for mitral valvoplasty except, okay? Leaflet length, leaflet mobility, leaflet thickening, leaflet calcification. Vote. Not, huh? Not part of the Wilkin score. Easy. Well, I think it's easy. Don't tell me you got it right. My target is to make you not win this time. Good, we'll see. طيب ما شاء الله 36 got it right, better than I expected. طبعا easy, you know them. The Wilkin score, most of you knows it. It's the leaflet mobility, thickening, calcification, and subvalvular thickening. It's not leaflet length. Good, so we'll see the scoreboard. Next. ما شاء الله ما. Nobody can compete. ولم الكار for him. Get ready for him. بعدين في ملدوخ got the second وحازم got the third ما شاء الله. And the people who were from the first round left already. Okay, next. 63 male with exertional dyspnea. This is the echo. Is it apical HCM, hypertensive heart disease, cardiac amyloidosis, or hypertrophic obstructive cardiomyopathy? How come? Wow. Good. Okay, vote for this. Oh, come on. No, no. It's okay, you can. But you have to answer fast. By the time you sit here in the top, most people get it already. So even if you cheat, nobody will win. Good. So we'll have the answer. So 33 got it right. Cardiac amyloidosis. Clear? Walla? I don't think we have to spend time عليها. The rest are wrong. Clear. Cherry on the top زي ما قالت الدكتورة. Clear. طبعا thickening, valve thickening, cherry on the top with sparing of the apex. It's classic for cardiac amyloidosis. Good. So we'll see the scoreboard. So Dr. Akram still on top, mashallah. Cherry on the top. Maldo the second and Hazm on the third. The rest are still the same. Good. We'll go next. Another quiz. What is that thing in the LV apex with the arrow pointing to it? Is it calcified false cord? Is it gun bullet from the case we heard today? LVAD cannula or thrombus? What do you think? That thing in the LV apex with the arrow. Tough one. If you didn't see it before, you will not recognize it. Okay, so 4 seconds, 3 seconds, 2 seconds. Okay, let's see. Wow, mashallah, 35 got it right. Well, next year should bring difficult questions. Good, so 35 got it right. It's a LVAD cannula. Clear, wallah. I'm just going to show you the next slide that shows what we're talking about. Wow, so Akram's still in the top, mashallah. I don't think he's cheating. Abrar in the second. وبعدين, sorry, okay, try not to move until I finish. طيب, this is the LVAD. So this is the, you see, what you see is the inflow cannula. So next year, I think we should specify whether it's inflow or outflow. Good, so clear to everyone, LVAD. Tomorrow we're going to hear about LVADs, inshallah. So good. Next, another quiz. 43 female with a murmur, and this is her echo. Is it membranous VSD, HOCM, subaortic membrane, and muscular VSD? Answer fast and correct. If you don't answer correct, you don't get points. If you answer slow, you get less points. Good, clear. I don't think in no games. Oh my God, it's clear diagnosis. Wallah, you agree? Okay, so we lost. It's okay, I know. Good. So I get 26 people get it right. So less than expected. Man, clear, صراحة. So it's, yeah, most of you recognize it. It's a muscular VSD in the muscle, يا جماعة. It's a muscular VSD. So some of you, I think, got. شوف الأنسر لا مش next. Just close this. Yeah. So 17 said it's subaortic membrane. I don't know why they said that, but maybe they were biased by the case presented by Dr. Shahata. Okay, so we'll see it standing now. Good. So, wow, yeah. Well, I did not do anything, wallah. Sorry, my friend. But Maldo on the top. Akram second. Shall we still in second place? You still. Abrar Al-Ali is number 3. وبعدين في جميلة وأكمل. أكمل, amazing. Good. So this is what I'm talking about. So this is a standing as of last night. Al-Hilal on top, like Dr. Akram. Al-Nasr, then Al-Ahli. And keep in mind, Al-Ahli, you know Al-Ahli? Yeah, they were not in the Russian League last year. So even if Al-Adala was not, next year inshallah. شوف ما فاز؟ مين يتكلم؟ العدالة out of the league خير شر جنبها. طيب كما بعض هنا المتسابقين يوردون خارج السرب. Okay, so we'll see. And this standing might change. We're still in the middle of the competition. Good. Okay, next question. What's wrong? Nothing wrong. Okay, is this a cleft mitral valve? Is it severe mitral stenosis? Is it mitral valve prolapse? Is it mitral annular disjunction?
This should be spot on diagnosis, straight up.
Yeah, don't overthink, huh? So we gave it more time than it needs, to be honest. Okay, so 36 got it right. Good, happy, wallah? Yeah, I'm happy, صراحة. Clear, it's cleft mitral valve. شايفينها في anterior leaflet. I don't think it needs more explanations. Clear spot diagnosis زي ما قالت زينة. Good, so we'll see the standing. Oh, mashallah. Maldu is still in the top. Akram is next. Then Jamila Jaber is the third. Abrar jumped from third to second to fourth, unfortunately. Keep in mind, only the top three will win, huh? So, yeah. Next. Apical four-chamber view with echo contrast shows. Is it apical HCM? Is it apical angiosarcoma? مش شايفين. Oh my goodness, sorry. Apical thrombus and non-compaction. You can see and vote. If you didn't see it, then everyone didn't see it, so don't worry. لا والله ما شافوه. والله شوي عندهم delay 10 seconds. Trust me. الأولوية للناس اللي هنا, to be honest. I think it's a priority for people who are here. Good, so 30 got it right. So it's apical thrombus. Can I see the media again? So why apical thrombus? Most of you got it right. طبعا ما في uptake. It's mobile. في wall motion abnormality. It's not apical HCM. لو كانت angiosarcoma حيكون في angio uptake للcontrast عشان it's a vascular. And it's not LV non-compaction. So it's LV apical thrombus. Clear? Clear. So most of you got it right. نشوف الستanding. Wow. Maldon first. Jamila number 2. Then Akram still number 3rd. Sorry, wallah, my friend. We'll see. Abrar al-Ali, then Akmal on number 5. Good. Next, we'll see. Things will change. لأنك أنت اللي يخرجون خارج أنت العين وغيره. A 36-year-old man with syncope. Select all correct answer. So multiple answers. So hypertrophic cardiomyopathy, mitral annular disjunction, systolic anterior motion SAM, ولا asymmetric septal hypertrophy. You can select multiple answers.
And press submit.
And press submit. Thank you for reminding us. Yeah. Once you select all the correct answer, you submit. The faster you are, the higher the ranking you will get, or points you will get. Easy, wallahi easy questions. Wow, good, good, good. So majority of you get it right. 37, yeah, so it's clear. واضحة الصورة. I think it's clear. Don't think you should spend a lot of time عليها. Asymmetric septal hypertrophy, huge. SAM, systolic anterior motion with hypertrophic obstructive cardiomyopathy. Good. عكست الإجابة. مين اللي عكس الإجابة? Yeah, so yes, yeah, fine. Revenge. You're on the board, my friend. Okay, so Akram is on the top again. Abrar number 2, Jamila number 3. Then Muhammad al-Hassan, mashallah, is catching up. Good, next. 26-year-old man with systolic murmur. This echo shows subvalvular aortic stenosis. It's a normal. Valvular aortic stenosis. Supravalvular aortic stenosis. Which one? Select one answer. Clear. You just saw it from the case's presentation. It's clear. Spot diagnosis. Wallah, Zina, I think. Yeah. What's happening, Mal? We're losing connection. Okay. Okay, so correct answer is 30. Got it right, which is subvalvular. Clear. شوف الميديا بس again. واضحة السب aortic ridge هذه. Clear to everyone, ولا? Yeah, في turbulence is clear obstruction. I don't have. Yeah. Good. Just want to move بس. Good. So شوف الرانكينج. Wow, Jamila is catching. Next. Which of the following is used commonly to follow patients receiving cardiotoxic chemotherapy? My favorite, easy. Is it radial strain, circumferential strain, longitudinal strain, or RV strain? And the image is showing it. يعني حتى إذا ما عرفت الimage is showing it. Which one? كلهم strain. So which one is commonly used to follow patients receiving chemotherapy? And tomorrow we're going to hear more about it, inshallah. Good. So 30 got it right. It's the GLS, global longitudinal strain. And clear, ولا ما يبي له وقت. Wow. والله العظيم sorry. I did not say anything. أنا أعرف نفسي نحس والله. طيب good. So Jamila is on number 4 والله. You're down. So Abrar and Akmal ما شاء الله is catching up. فما شاء الله I'm happy to see the dynamic change اللي صاير هذا. So longitudinal كم نتيجة المباراة؟ longitudinal strain هذا longitudinal strain. Tomorrow you'll hear more about it. So we'll skip this. Next question. So you can catch up. This aortic valve is it unicuspid, bicuspid, tricuspid, quadricuspid? Easy. Spot diagnosis. اللي ما يجيبه صح خلاص we'll finish the game. Yeah, you just need to count and have a good screen. Yeah, count now. يلا more. Easy, straightforward. It's different than the case just presented. عشان بس to give you hints. So 24 get it right. So 4 quadricuspid. So the case we just presented unicuspid. This is 4 cuspid, and let's see the ranking. Oh, Jamila, you're on top. Okay, so you're catching up. I think only one question left. So Akram, Abrar, then Jamila. So mashallah. So up and down, up and down. زي الهلال والاتحاد والأهلي. الاتحاد وين؟ وين الاتي السنة هذه؟ كنسارة. Where is the اتي? Oh yeah, صح صح. أتمنى إنه either أبرار ولا جميلة will win with all. Yeah, we'll see. عشان International Women's Day. بالله last question try to be slow شوية عشان الwomen يفوزوا بس. Well, شكله يلا last question answer fast and quick. Which cardiac structure is not seen in this image? Easy. Left atrium, right atrium, left ventricle, coronary sinus. Not seen. You answered, mashallah. Good for you. He's cheating. Which one is not seen, ya jama'a? Easy. Wallah, very simple question, but people take some time to answer. Good. So this is the last question, and depends on this question, we'll know the winners, inshallah, and the prizes will go to. So, mashallah, oh, interesting, wallah. أتوقعتها والله coronary sinus. Yeah, that's what I expected. So coronary sinus, show media. Show media again. So 24 get it right. Right atrium. You're not seeing right atrium here, but this is the coronary sinus. So you see the coronary sinus.
If it's dilated, obviously it's more clear. Yeah.
في coronary sinus. I swear to God, I spent a lot of time reviewing a question عشان أتأكد إنها صح مش زي أسئلة الهيئة. طيب نشوف الآن الوينرز. أتمنى إنه ما تغير أو إنه أتليست جميلة فيميل. So number 3 دكتور أكرم number 3. Oh, thank you. جزاك الله خير. والله good.
A true gentleman.
Yeah, جميلة number 2 and the winner number 1 is أبرار. ما شاء الله. Who's أبرار?
Congratulations.
أبرار is female هنا أبرار. ما شاء الله تبارك الله. Well done. So women's win. Woo! Nobody told me. طيب. Good والله I like it والله. Very good والله. Good. So ما شاء الله دكتور أكرم أبرار and جميلة are the winners. طبعا أبرار will get the highest prize لأنه number 1 وجميلة number 2 وأكرم جزاك الله خير والله. هذا تصرف جميل عشان International Women's Day and it will count in your CV والله. Just write it. I intentionally did this for the International Women's Day. Good. Okay. So ready for second part? نلعب السكند بارت. I promise نصلي ونرجع بس بالله الصلاة بس سريعا عشان بس لأنه يا سفري قصرا وما تقصر المغرب. طيب good. لا بقى بارت 2 بعد الصلاة بس صلوا بسرعة ارجعوا يعني صلوا ركعة ونص ما يخالف.